insidiously depending on the difficulty of the patients, and involve them early and stabilize the patient early and shift the patient to the cath lab to save the heart muscle and the nerves.
In our level 1 cardiac,
స్టార్ట్ అయ్యింది చూసాను. నువ్వు ఇందాక క్లీన్ చేసి కావచ్చు.
curated for medicine MBBS కదా cardiology దాంట్లో చెప్పినట్టు చెప్పబాక presentation సార్ for physicians
అదే ఓకే
Tuesday అరేంజ్ ఉండిపోతున్నారా
ఆడియో రాకపోతే ప్రాబ్లం ఆడియో వస్తుంది కదా ప్రాబ్లం స్ట్రక్ అవుతుంది.
Patients are quite unstable to do any kind of angiogram or angioplasty. But with the emergence of level 1 cardiac emergency care, so we can change outcomes in these patients.
To deal these critical ill patients, we have a structured policy and protocol at our Medicover hospital. We have a team of doctors who can rapidly triage, assess, resuscitate, and stabilize the patient in the departments within minutes. And we know in ACS, time is muscle. We involve the ACS team or MCS team depending on the criticality of the patients and involve them early and stabilize the patient early and shift the patient to the cath lab to save the heart muscle at the earliest.
In our level 1 cardiac emergency care, our team of experts, including interventional cardiologists, mechanical circulatory team, and post-care team, comes together within no time to take care of things for these kind of patients. We put Impeller or BA ECMO, which are available on site in the hospital within no time to the patient, and then we complete coronary angiogram and subsequent opening of blood vessels.
Once the patient is shifted out of the cath lab, he comes into the ICU. He needs intensive monitoring, and we have 24 hours critical care coverage where the patient is monitored for his heart rate, blood pressure, and continuous ECG monitoring. Any changes in the ECG can be taken care of immediately and we can be corrected with medicines or defibrillation. The hemodynamic monitoring, there is blood pressure monitoring, can be done continuously or intermittently and can be taken care of immediately when required. The patient, if requires any ventilator support or the renal replacement support, can be provided in the ICU itself.
The best cardiac results come when you handle the patients in the golden hour. In Hi-Tec City, Madhapur, we have 25 cardiologists, experienced hands working around the clock to give the best cardiac output in this part of the country. So you have cardiologists who can do a primary angioplasty anytime during the day and night, 24/7, 365 days a year. So that, our blood to balloon time, which determines the success rate or the results, is less than 40 minutes from the time the patient consents for the primary angioplasty. It gives immense pleasure and satisfaction that we are doing the utmost complex procedures with very low risk. The most complex angioplasties, multi-vessel stentings, where many patients were being rejected in many of the centers. We are taking care in this facility. We stand tall shoulder to all the people are delivering the best of the cardiac outcomes.
Cardiology is not just about the heart rhythms, it is about the symphony of life that beats within each of us. Good afternoon, ladies and gentlemen, distinguished guests, and esteemed colleagues Medicover Hospitals welcomes you to today's seminar on latest updates in cardiology. It's a privilege to have each and every one of you here today as we embark on the journey of knowledge. It is with great pleasure that I, Dr. Raidurgam, stand before you for next few hours as we delve into the intricacies, challenges, and advancement in this field, all while fostering meaningful discussion and exchange of ideas. May I now call upon Dr. Anusha to come over the dais and give introduction on Medicover Hospitals.
A very good afternoon, one and all. Medicover is the largest healthcare providers in Europe with a significant presence in India. It is globally recognized healthcare brand with operations in 12 countries. Medicover is a leading multi-speciality hospital chain with a significant presence in India. We provide a broad spectrum of healthcare services and have an extensive network of clinics, hospitals, specialty care facilities, fertility centers and diagnostic labs with 21 multi-speciality and cancer hospitals and 2 OPD centers, which are soon going to be 25 hospitals and 2 OPD centers by the end of this year, spread across 4 states of Telangana, Andhra Pradesh, Maharashtra and Karnataka, treating millions of patients every year with a focus on augmenting healthcare standards in India. We have renowned medical teams who work with the greatest technologies and international evidence-based protocols which offer the most comprehensive treatment across all specialties of medicine, raising the standards of healthcare in India. The Department of Cardiology at Medicover Hospitals, Hi-Tec City, Hyderabad is a renowned center of excellence for cardiology in Hyderabad of Telangana. Our state-of-the-art facilities, infrastructure and advanced technologies for acute, chronic and critical cardiac diseases and conditions ensure excellent treatment outcomes for the patients. The cardiology department at Medicover Hospitals offers best treatments with the latest technology and top-notch specialists with best practices in emergency cardiac services and minimally invasive interventions and surgeries. The cardiology department at Medicover Hospitals is an integrated health center with a highly trained, skilled and committed team of heart surgeons, cardiologists and radiologists working in full collaboration to provide comprehensive and multidisciplinary treatment to patients suffering from varied heart disorders. The interventional team is accessible round the clock to render assistance and ensure quicker recovery. Cardiac Institute is fully equipped with the latest electrophysiology lab with a 3D mapping facility to assess and remove different forms of arrhythmias. We hold the best in the state for device implantations like ICDs and CRT. We have wide range of cardiology equipments like ECG, echo, coronary angiogram, 16-slice CT coronary angiogram, color Dopplers, Holter monitor, rotor ablation, IVUS, FFR, electrophysiology, radiofrequency ablation and CM. We have a track record of success in heart transplantation, minimally invasive surgeries, advanced cardiology procedures, intervention cardiology, electrophysiology and cardiac rehabilitation, making us one-stop cardiology destination for all cardiac disorders in Hyderabad. We excel in performing complex surgeries and procedures with the help of latest technologies and devices such as Impella and LVAD, yielding highly successful outcomes. At the outset, I would like to welcome you all to this prestigious grandeur of an event where we have all our renowned team of cardiologists and cardiac surgeons actively interacting and sharing their vast knowledge, expertise and experience with each one of us. It is indeed a great pride and privilege for all of us present here to be associated with the most dynamic leader in the healthcare domain in India, that is Medicover Hospitals. Thank you.
Thank you, ma'am. Now I would like to invite the dignitaries from the dais. Dr. Anis Krishna, Senior Consultant Interventional Cardiologist, Chairman and Managing Director of Medicover Hospitals, coronaries. He is well known for handling critical situations and has performed a number of complex interventional procedures. His aim is to expand pan-India and overseas and deliver European standard healthcare excellence to everyone in need of quality healthcare.
ఇచ్చి తీసుకుంటా
I now take the privilege of inviting Dr. Sharat Reddy, Executive Director, Senior Consultant Interventional Cardiologist, Medicover Hospital.
నిన్న ఫస్ట్
Hello, bhai. Dr. Sharat Reddy is one of the few to be ranked in the League of Eminent Cardiologists in the country. He specializes in the interventional cardiology and
Hello, brother.
He has fellowships in various international cardiac societies, including American College of Cardiology, American Heart Association, Society for Cardiovascular Angiography and Interventions, and European Society of Cardiology. May I now invite Dr. Sridhar, Program Director of Latest Updates in Cardiology, to this program. Cardiologist of Medicover Hospital. Sir is an experienced interventionist and has performed more than 5,000 angioplasty procedures. He is also expert at device closure of heart defects like atrial septal defects, ventricular septal defects, and PDA. Under his esteemed leadership and guidance, Medicover Hospitals has recently launched Medicover Journal of Medicine. A copy of each journal was provided in the folder during the time of registration. Ladies and gentlemen, please join me in welcoming Dr. Krishna Prasad, Director and Chief Consultant, Cardiothoracic Surgery. Sir's expertise in MICS, coronary artery bypass surgery, and total intracardiac repair. Esteemed doctors, as we gather to illuminate the path towards excellence in healthcare, we cordially invite our dignitaries for the lamp lighting ceremony. Your presence and participation in this symbolic gesture will not only mark the beginning of our event, but also signify our collective commitment to healing and compassion. I now request all the dignitaries to light the lamp and mark the beginning of our event on a meaningful note. dignitaries, I want to take a moment to extend my heartfelt gratitude for your participation in the lamp-lighting survey at the onset of latest updates in cardiology program. Your presence on stage not only inaugurated the event with distinction, but also set tone of excellence for the invaluable discussions to follow. Ladies and gentlemen, esteemed dignitaries, as we gather here today to commemorate this program, I would like to take a moment to invite each of our distinguished dignitaries to share their thoughts and insights with us. Each one of them brings a wealth of experience and expertise to this gathering and their perspectives. I now request Dr. Anil Krishna to address the gathering.
Thank you for the introduction. And distinguished guests, doctors, friends, colleagues, we welcome you for the latest updates in cardiology conducted by the Medicover Hospitals Department of Cardiology. As you all know, cardiology across the globe is making rapid strides, and newer things getting added so as to benefit the patients, to give a better outcomes, comfortable recovery, and a less invasive approach to the cardiac care for the needy people. So on this note, there is this latest updates by medical hospitals in field of cardiology is to enrich our knowledge towards what is presently happening and what best we could do to the cardiac patients for their better outcomes. As you know, the team of cardiology from medical hospitals, the uniqueness is this team is practicing together for the last 15 years together, innovating and encouraging each other, supporting each other, and involving in getting the newer technologies to the hospitals. This team of cardiology is experienced in all the latest gadgets, right from impellers to the ECMOs to the LVAD program or to the rotablations, the IVSs, the OCTs. You mentioned it. The latest technology which is available across the globe is present in this hospital, and this team is equipped. So whoever is speaking to you today, or whichever topic it is, these people are hands-on onto those techniques. So it will be more, a hands-on experience which they will be sharing. I hope this will add to give a better outcomes or maybe insights into the latest cardiology updates available and latest form of treatments, which involves giving life to the sickest patients, getting less invasive approach, and what are untouchable and untreatable becoming treatable these days. I hope you have a great interactive session, and I wish all the dignitaries on the stage and even the speakers a warm welcome and all the best. Thank you.
Thank you, sir. Dr. Sharath Reddy, sir, your presence on stage presents an opportunity for us to hear your thoughts on today's program. Would you mind sharing a few words, sir?
So, dear respected patrons of Medicover hospitals, so the reason why we are organizing this program for all our patrons, the ideation came from one of my patients. So, after going through all the reports and everything, I advised the patient, I think this is a therapy recommended for you. And the patient immediately answered, sir, let me go back to my primary healthcare physician and come back to you. So, in our country, it is still the trust between primary healthcare physician to the patient is almost, still at the pinnacle. So, and it is very important for all of us to be in one page so that we can deliver right care or right service at the right time to the right patient. So, and that is the reason why we are organizing. So this a broader view of what is going on in cardiology and the latest advancements which are available now to treat complex and high-risk patients, which you all should also have some idea about it, so that you can really help your patient at right time. Because we all know how time-sensitive are cardiac procedures. See, sometimes it is like battle between you and Yamadharma to bring the patient out of the clinical situation he was in. So, and that's how fast you have to take decisions in these patients. So, having knowledge on all these, broader knowledge on all these things, for all of you, helps us also, to deliver care in a right time. So that's the whole idea behind this program. So we are really glad and delighted to see so much of enthusiasm, exuding enthusiasm in all of you to know the advancements in cardiology and cardiac surgery. And as a responsible organization, we also recently introduced, which Dr. Kritika was talking about, we introduced a journal which we are publishing every month. So I think it is there in the handout which was given to you, so you can go through it. And if any of you, wants to, publish your, data, so our team is always there to help you out in navigating, these publications. So, we take that responsibility for all our patrons sitting here. And I think I won't take much time, so we'll move on to the program. Thank you all. Yeah.
Thank you so much, sir. Dr. Sridhar, as one of our esteemed dignitaries seated on the stage, your perspective on today's program would be valuable, sir. Could you please share a few words with the audience?
Good evening all. A warm welcome to you. Dignitaries, our visionary founder, chairman, and he himself an excellent cardiologist, Dr. Anil Krishna, and my mentor, teacher, and a complex interventional cardiologist, Dr. Sharad, our ace surgeon, Dr. Krishna Prasad, my senior cardiologist, Dr. Balaji sir, Kumar sir, and my colleague speakers, and you all audience. Hearty welcome to you all. So I think I'm happy to see a great crowd here. Thanks for taking time. So we have tried to curate most of the useful topics in the today's session. Basically, the idea as said was by the Dr. Sharad, and just being used as a channel to create this program. So I thank our speakers who has taken time to prepare. So probably in the next 2 to 3 hours, we will be having a feast of clinical cardiology as well as interventional topics. I think in between the sessions, you also have some question and answers. Sessions will be there. The mics will be given to you. You can ask any questions. So we will be happy to answer, also interact one-to-one with you. So I think we'll be starting the program. Thank you.
Thank you so much, sir. We would greatly appreciate if Dr. Krishna Prasad can shed light on today's program.
Good evening, one and all. My colleagues Anil, Sharad, we've been together, and Sridhar, we've been together for 13 years. I'll just take a couple of minutes. As Sharad mentioned, it's so nice to see so many people enthusiastic about knowing what's happening in cardiology. In these busy days where we don't barely get time to read or go through what is there on the internet, these kind of meetings are perfect, and it's been made into a short time. It's only 2 to 3 hours, so you don't miss out on your entire day. At the same time, you get a glimpse of what's happening. And these are experts who are working in their fields, so they give you their essence. So the best way to know is, again, question. If you have any questions in mind, please do ask. And in Medicover, we have a practice of heart team. So the entire team sits together and comes to a decision about what's the right treatment for the patient. So here also, all of us will know about every aspect of cardiology. And if you have any queries, borderline cases, which consultant to go, who will be dealing with what, hopefully this session will give you those answers. And I hope you will all go back home with a halo around your head, more cardiology in your heads. So let us start the session with the lady. Thank you.
Thank you, sir. I request our esteemed dignitaries to take their seats in front of us. Ladies and gentlemen, as we commence this seminar on latest updates in cardiology, it is imperative that we lay a strong foundation by addressing our first topic, clinical cardiology. I invite the moderators of this session, Dr. Sharath Reddy, Senior Consultant Interventional Cardiologist, Medicover Hospitals, Dr. Nitin, Senior Interventional Cardiologist, Medicover Hospitals, Dr. Kumar Narayan, Senior Consultant Cardiologist, Electrophysiologist, Medicover Hospitals, and Dr. Ashirwad to come on the dais. Join me welcoming Dr. Shiva Prasad Naidu, Consultant Interventional Cardiologist, to share his expertise in ECG interpretation in acute chest evaluation.
Good evening, everybody. I welcome you all in this evening for the Medicover cardiology update. So, my topic being ECG interpretation in acute chest pain evaluation. So, chest pain is the most common presentation in acute emergency. So, it's almost 5% of the cases will present to the emergency department. So, among these, almost 31% of cases are acute coronary syndromes. So acute coronary syndrome will encompass around 31% of the cases which present to the emergency room. So these are the majority of cases. So you have to deal with acute coronary syndrome majority of the cases which present to the emergency room. Other emergencies being pulmonary embolism, pneumothorax, pericardial tamponade, aortic dissection, and esophageal perforation. These are the emergencies we have to deal with. We have to fastly, we have to recognize all these conditions, otherwise mortality will be more. So acute coronary syndrome is a clinical clinical diagnosis where symptom analysis is most important along with signs, and the basic profile you have to see the patient is hypertensive, diabetic, hyperlipidemic patients, elderly patients like that. You have to see in the background of risk profile, and so you have to do the symptom analysis. That's most important before coming to the investigations. So the first and foremost is electrocardiogram, which is readily available in the emergency room, followed by echocardiogram and biomarkers, which are helpful. So these are the high-risk patients which present with acute coronary syndrome, basically male, elderly patients, diabetics, previous CKD patients, and peripheral vascular disease CVA and peripheral vascular disease patients, previous CAD patients. These are the high-risk patients which usually present with acute coronary syndromes, so presenting otherwise. So in the symptom analysis, positional chest pain, nature of the pain, radiation, aggravating relieving factor, these are the most important. The positional chest pain, the retrosternal pain is typical of acute coronary syndrome. So usually it will be oppressive, vase-like and constricting in nature. That's most goes in favor of acute coronary syndrome. Whereas piercing, stabbing, and pins and needles, which associated with tenderness on the chest, may be goes against acute coronary syndromes. So next, radiation is also important. So this acute angina pectoris, the chest pain of acute coronary syndrome usually radiates to. So usually radiates to usually left arm, shoulders, neck, back, sometimes to the epigastrium. So confusing with the abdominal symptoms. So anything which is radiating below the umbilicus may not be acute coronary syndrome. So it should be usually above the umbilicus, and it may also radiate to the jaw. And associated features like breathlessness, diaphoresis, fever, chills. Fever chills may go in favor of pneumonia, and abdominal dyspeptic symptoms go in favor of GERD. Aggravating relieving factors are important. Acute coronary syndrome chest pain usually aggravates by taking exertion and relieved by taking rest. This is the most important symptom you have to ask for. This is a classic Levine sign. So patient usually have So this is a classic Levine sign. Patient keeping his fist on the chest. This is a classic symptom of acute coronary syndrome. So associated clinical signs like hypertension, raise or pulmonary edema, transient mitral regurgitation, and presence of LVS3. These points clinch the diagnosis of acute coronary syndrome. You have to look for them. So these are the high likelihood of ACS features like retrosternal chest pain, heaviness or burning, radiating to left arm or jaw, throat, lasting for more than 20 minutes duration, diaphoresis, which is new onset in nature and reproducing with previous documented angina. These are the high likelihood features of acute coronary syndrome. So, and sometimes this chest pain may not be present in some cases like elderly, diabetics, post-CAD patients. These are the patients in whom chest pain may not be present. There may be anginal equivalents like breathlessness, diaphoresis, giddiness, psychiatric disturbances. These are the anginal equivalents sometimes in this kind of people. So there are various differential diagnoses for chest pain. So numerous causes like non-ischemic cardiovascular conditions like aortic dissection, which is an important condition we have to look for. and myocarditis, pericarditis, hypertrophic cardiomyopathy, tachycardic cardiomyopathy. So among these, we have to look for aortic dissection, pericarditis, importantly. And other chest wall disorders like cervical disc disease, costochondritis, herpes zoster, and neuropathic pain, rib fracture. These are the musculoskeletal conditions. Usually, these young people will have these conditions. And pulmonary embolism is one of the differential diagnoses we have to look for because it also has high mortality. And gastrointestinal symptoms like cholecystitis, peptic ulcer disease, GERD, and vasospasm. So vasospasm also get relieved by nitrates sometimes. So, but the relief with nitrates maybe after 10 to 15 minutes of taking nitrate, rather than acute coronary syndrome where with nitrate, the relief with nitrates will come soon after, within 5 minutes like that. That you can differentiate. And spasm usually associated with food intake usually. And other psychiatric disturbances, anxiety, depression, so these are all associated with chest pain syndromes. So these are the killer causes of chest pain like acute coronary syndrome, aortic dissection, acute pericarditis, acute pulmonary embolism. In acute aortic dissection, there will be central chest pain or back pain which is dissecting in nature, spacing in nature. And there will be pulse deficits, there will be unequal pulsations in the upper limbs. And acute pericarditis, the pain will be usually pleuritic in nature and relieved by stooping forward and aggravated by the lying down position. So, an acute pulmonary embolism, usually there may be central chest pain or peripheral chest pain. So, there may be pleuritic. So, associated clinical conditions like immobility, aid travel. So, all these clinical features will aid in diagnosis. So, after taking history, we go with the investigations, ECG. Preferably, you should do the ECG in the ER within 10 minutes of arriving to the ER. You have to read the ECG within 10 minutes. And sometimes the initial ECGs may be normal, first ECG may be normal, second ECG may be normal, third ECG may become abnormal. So serial ECGs are very important. And 2D echo will aid in the diagnosis of acute coronary syndrome. And chest X-ray, tension pneumothorax, it will delineate. And troponin levels. Troponin levels will aid in the diagnosis of acute MI. And also it will prognosticate the patient. And the CT pulmonary angiogram will aid in the diagnosis of pulmonary embolism. So the ECG should be taken immediately, and serial ECGs are must. And look for ST elevation, depression, TVF changes, new onset LBBB, rate rhythm, any AV blocks are there, and evolving changes. This should be looked for. So after confirming clinically it is yes, do the ECG. So if it is ST elevation, it is ST elevation MI. So there is no ST elevation, or there may be ST depression or TVA immersions, or there may not be any ECG changes. Then go for troponins. If this troponin is positive, maybe non-ST elevation MI. If the troponin is negative, maybe unstable angina. These are the spectrum of acute coronary syndrome: STEMI, unstable angina, and STEMI. This is a spectrum. One may convert into other. The unstable angina may convert into STEMI, STEMI may convert into STEMI soon. So you have to expedite the condition. So coming to the coronary circulation, there are three vessels supplying the heart. So LAD, LCX, and RCA. LAD usually supplies the diagonals and subducts, and it goes to the anteriorly and towards the apex. It may wrap around the apex. And LCX, it will supply the lateral wall, posterior wall, whereas RCA supplies, so atrial branch, it gives atrial branch, conus artery, acute marginal branch. This supplies the RV free wall and also supplies the inferior wall. So STEMI ECG criteria, usually ST elevation involving more than 2 contiguous leads, at least 1 mm ST elevation. So in V2, V3 leads, the measurements will be more. So in case of men less than 40 years, it is more than 2.5. In case of men over 40 years of age, more than 2 mm. And in women, it is 1.5 mm in case of V2, V3 leads. So in other leads, it can be more than 1 mm. So sometimes these measurements may not be enough in some cases. So sometimes even subtle ST elevations we have to look for. So no need for 1 mm elevation. The clinical condition of the patient we have to see and associated ECG features. Even they are subtle, we have to go with the diagnosis of STEMI. And new LBVB also should be looked for, and new onset of LBVB otherwise proved as a old LBVB should be treated as fresh LBVB and should be considered as acute MI. So this is this segment is convex supports, like the convex supports in STEMI, and this is saddle shaped or concave upwards in case of pericarditis and other non-STEMI syndromes. So evolution of STEMI is usually like this. Initially the upper acute T wave formation within minutes, later followed by ST elevation, J point elevation, and later followed by Q wave formation, and gradually there will be ST resolution and T wave formation will occur. So this is the evolution of STEMI. So STEMI will be more often inferior wall MI in 58% of the cases, and anterior MI in case of 39% of the cases, other 3%. So RC occlusion usually 45% of the cases, LCX 12% of the cases, LED in 36% of the cases. So usually how the ST elevation usually appear on the 20 ECG. It is usually based on the injury vector which is directed towards the injured area and generating ST elevation towards the injured area. The opposite segment, the tail, shows the ST depression, that is reciprocal depression. Leads perpendicular to the dominant vector will record isoelectric segment. You see, this is the LED, proximal LED occlusion where this is the injured area. Hence, the vector will be towards anterior and lateral side, so there will be ST elevation in event before. The reciprocal lead usually inferior lead shows ST depression. This is the distal LED occlusion where so only this portion is injured. So the vector will be downwards. So only V4 to V6 or even V4 to V6 lateral leads, and also sometimes the LED will be wrap around so that inferior segments also get elevated. So accordingly, the injured vector, how it goes, so which, where it is, the artery is blocked, that denotes the elevations. This is inferior MI where this RCA culprit, here the ST segment injury vector will be downwards inferiorly and to the right, so involving the ST elevation in inferior leads, and opposite side the reciprocal segment L1 will show the depression. In case of LCX, the injury vector will be downwards and causing inferior ST elevation and also towards L1, so that the L6, the lead 1 will show the elevation. So the differentiating point between RC and LCX. So these are the leads, the nomenclature, anterior and septal. These are the lateral leads. This is the inferior to L3 MEF. So the lateral leads usually supplied with LCX, shows the LCX and diagonal of LED. Inferior leads usually RC and LCX, and septal leads LED. So these are the septal leads, anterior leads, lateral leads. So when this LED is involved, so it has combination of leads involved with ST elevation. So septal MI denotes V1 to VT leads, and anterior V2 to V5, anteroseptal V1 to V4, and anterolateral V3 to V6, and lateral leads alone and area. And there is extensive anterowall MI. So all the leads anteriorly and also alone and area will show ST elevations. So if you see upper acute anteroseptal STEMI, there is tall T waves. Tall T waves are there. So the upper acute STEMI. So here there is ST segment elevation, there is PF formation, there is also acute STEMI. It's evolving anterowall MI where QFs already deep, QFs already formed. There is resolution of the ST segment and already QFs are inverting. So this is evolving anterowall MI. So how the ST elevations will appear on the collated ECG. How the injury vector is there will behave like this. Suppose the LAD it is blocked here, so there will be huge area of infection will be there. So the injury vector will be upwards. So hence this AVR, AVL, these will show positive ST elevations, and these reciprocal leads will show negative, that is ST depressions. So there will be ST elevation in anterior leads, V1 to V6, ST elevation in AVR, and ST depression in inferior leads, and also V5, V6. So see, it is a proximal LAD total block. So you can see how the anterior leads and also L1, AVL are involved with ST elevation, and reciprocal ST depressions are there. So here extensive anterior MI, all the anterior leads are involved V1 to V6, and also L1 and AVL along with reciprocal depressions in inferior leads. This is stoning pattern where ST segment will go beyond the R wave and fuses with the smoothly with the R wave. So this is called stoning pattern. It's very sick case, so have higher complications. So this is also one of the ECG feature of hostile LAD occlusion, where there is QRBB pattern, Q wave with RBBB. This also potent grave prognosis on the patient. So this is the distal LAD occlusion where the blockage is here. So injury vector is downwards because the injury area is less. So the directed downwards where the ST segment elevation will be in V5, V6, and sometimes the LAD will wrap around. So going supplying the infra also some distance. So there will be ST elevations in inferior also. So there will be elevations both anteriorly and inferiorly. So ST elevations in anterior leads along with the inferior leads. So this is the LPB pattern, so should be considered as an MI unless proved otherwise, where there may be old ECG with the patient with old LPBB. In those cases you can consider it, you can take the Garbosa criteria to deny to the fresh ischemia. So this is the ECG taken after a few weeks. So in this case, the evolution changes has not occurred, and there is still some ST elevation is there. So this denotes left ventricular aneurysm, and also this also denotes large area of infarct. So ST elevation in AVR should be sought in any case with serious acute coronary syndrome. So there is ST elevation in AVR with coexistent multi-lead ST depression indicate subendocardial ischemia due to O2 supply or demand mismatch. The ST elevation in AVR may be due to two conditions. One is myocardial ischemia, one is due to subendocardial ischemia. So subendocardial ischemia due to hypoxia or hypotension. So for example, following resuscitation from cardiac arrest, these patients will have subendocardial ischemia because of cardiac arrest and other comorbid conditions, hypotension and all. So myocardial ischemia due to LMCA, currently LMCA stenosis or occlusion, proximal left anterior LAD stenosis and severe closure disease. So these three conditions will also cause ST elevation in AVR. So this denotes myocardial ischemia rather than subendocardial ischemia. You see, there is band ST depressions in all leads except AVR. So ST elevation in AVR and reciprocal depressions, band depressions in all leads. So this denotes LMCA lesion, severe closure disease. So predictive value of ST elevation in AVR. So AVR and ST elevation has predictive value. So more than 1 mm ST elevation in AVR, it may indicate proximal LAD or LMCA stenosis. And ST elevation is not there, then it almost entirely excludes significant LMCA lesion. So in context of angiostomy, there is AVR elevation is more than 1 mm. It's highly specific for LAD occlusion proximal to the first septal branch. In patients undergoing exercise testing, so the ST elevation is more than 1 mm. It may indicate LMCA stenosis or hostile LAD stenosis in case of exercise testing. So magnitude of ST elevation in AVR lead also is correlated with the mortality. So more the ST elevation, more the mortality. So this is a case with the LMC and 95% stenosis where there is a pan-ST depressions with elevation in AVR. There may be elevation in V1 also. So this is a case with the LMCA and tuberculous disease, similar feature, pan-ST depression, elevation in AVR and V1. The severe multivessel disease, so similar picture can occur. This is a case of tachycardia-induced cardiomyopathy, tachycardia-induced ST depressions. There is SVT, supraventricular tachycardia. Because of tachycardia-induced depressions, there will be pan-ST depressions with ST elevation in AVR. So this is not due to LMC occlusion, this is due to tachycardia-induced subendocardial ischemia. In these cases, suppose after subsidence of tachycardia, the ST changes persist, then you may consider underlying coronary artery disease. Otherwise, usually these ST depressions will resolve. So this is a patient, an old man with acute blood loss, so with hypertension, anemia. So in this patient, because of hypertension, subendocardial ischemia occurred, and there will be ST, pan-ST depression with associated elevation in AVR. So in this case, there is no LMC occlusion, but because of hypertension and all, patient has got this type of picture. It is subendocardial ischemia rather than LMC occlusion. So it's inferior MI where there is IC detected here ST elevations in inferior F2, 3 AVF along with reciprocal ST depression in AVF. So in case of inferior wall MI, so you have to right-sided leads, because in case of inferior wall MI, 40% of the cases we have right ventricular infarction. So in these patients, if you give nitrates, there will be severe hypertension. So hence, all inferior MI cases should receive the right-sided leads to know whether right ventricular infarction is there or not. And you should see for second degree or third degree block which are common with inferior MI, and posterior wall extension should have to sought for. So don't neglect AVL in case of inferior MI. Sometimes there will be only one feature, subtle ST elevation in AVL along with ST depression. Sorry. So ST depression in AVL, subtle ST depression in AVL, only there will be subtle inferior STEMI that do not meet STEMI criteria, but still occlusion on PCA demonstrate ST depression in AVL. So there will be subtle changes elevations in inferior wall, but AVL shows depression, that shows maybe occlusive MI. So how to differentiate between RC occlusion and circumflex occlusion? So in RC occlusion, there will be lead 3 will show more ST elevation than lead 2. And there will be presence of reciprocal ST depression in lead 1, and also associated right ventricular infarction always indicate that it is a RCA. Circumflex occlusion, usually ST elevation will be more in lead 2 than lead 3, and absence of reciprocal ST depression in lead 1. So goes in favor of circumflex as the LCX will face the lead 1, so there won't be any depression. And along with ST elevations in lateral leads denotes circumflex occlusion.
Dr. Shiva, I think you're going beyond time. Yeah.
So this is the distal RC occlusion where there will be ST elevation. Lead 3 shows more than the elevations in lead 2. There will be ST depressions in anterior leads. So this is the same inferior MI with ST depression in AVL and ST elevation in inferior leads. Lateral MI usually occurs as part of the anterolateral stematoid occlusion or LCS occlusion. Isolated lateral infection usually occurs due to diagonal and boeing occlusions. So this is elevation in L1 and AVL, bilateral MI. so anterior and lateral. This is lateral MI assessed with LCL subclusion, inferior elevations and lateral elevation. This is a posterior MI where there are no actual posterior leads represented on the chest. So these are the V1, V2, V3 are the leads present on the chest facing the posterior wall oppositely. So hence there will be mirror images. Instead of ST elevation, there will be ST depression and tall, broad, symmetrical T waves, and R by S ratio is more than 1. This is a typical of posterior wall MI. So then you have to see for a posterior wall MI by putting these leads V7, V8, V9 posterior leads. So these are the leads showing V7, V8, V9 leads showing ST elevations in case of posterior wall MI. So these are the anterior leads showing ST depressions. The same patient, if you put V7, V8, there will be ST elevations. So in case of inferior MI, with RCA occlusion, you have to put right-sided leads. So V4R is a specific lead for RV infarction. So there will be ST elevations in these leads. So see for ST elevation in V1 associated with inferior changes. V4R ST elevations. So ST elevation in inferior leads associated with ST elevation in V1. Sometimes V2 may be depressed and ST elevation may be there in V1. This is specific for RVMI. So another means of ST elevation is Osborne waves and hypothermia. There is ST elevation, J-band elevation. This is fishhook appearance. So this is typical of hypothermia, Osborne waves. Acute pericarditis shows band depressions, band ST elevations in all the leads except AVR, where there will be ST depression and PR segment elevation. Other leads, band ST elevation will be there and PR segment depression will be there. So coming to non-ST elevation, ACS.
Shall we conclude and because this is one important topic where we have to give a lot of take home for our audience. Yeah.
So coming to ST depression, there will be upsloping depressions, downsloping depressions, and horizontal. This is more specific for ischemia rather than these two. So this is mostly physiological. This is maybe non-specific but important. So ST segment depressions due to subendocardial ischemia or myocardial ischemia. So TVI inversions, the more the TVI inversions, more the grave prognosis. So see for more than 1 mm ST TVI inversion and more than 2 contiguous leads. So these are the TVI inversions in one area with lateral leads. So inverted TVS in case of sometimes patient will present with inverted TVS, inverted U waves. So these also may generate ischemia. These are the U waves present in V5, V6. This is a specific pattern, D-inter pattern, anterior extremity equivalent. So in this case, there is ST depression rather than ST elevation with tall T waves usually present in anterior leads. This may progress to anterior one. Then the D-inter T waves.
Dr. Shiva, I think we'll move on to a little bit conclusions, or we'll move on to some questions from audience, if you're okay. Yeah. Sorry for interrupting you, but
so in the emergency departments, you search for emergencies like acute coronary syndrome, pulmonary embolism, tension pneumothorax, pericarditis. These things should be borne in mind, and we have to execute these patients as soon as possible.
Yeah, thank you, Dr. Shiva, for your comprehensive presentation. But I think, we have to, though we are way on time, we'll try to dwell a little bit on chest pain, because this is a fulcrum of cardiology practice, right? So, the few take-home messages: if a patient is coming to you with a chest pain,
chest pain associated with sweatings, and he is sweating in front of you. That is acute cardiac syndrome. It is acute coronary syndrome. There is no need for ECG also. See, what we have to understand, acute coronary syndrome is a clinical diagnosis. It's not an ECG-based diagnosis, not an echo-based diagnosis. It is still, even at this time, it is only a clinical diagnosis. ECG shows changes only in 50% of patients. 50% of patients, there won't be any ECG changes. So, understanding clinical syndrome is key. So, any chest pain, sweating in front of you, it is nothing but acute coronary syndrome. You can take ECG. ECG helps only classifying patients, what kind of acute coronary syndrome. Is it STL Vaishnamai, non-STL Vaishnamai? So, and another, see, if the patient had a chest pain, he reached your hospital. And often, ECG will be normal in those patients. So, it is a clinical diagnosis which is important. So, I think, anything, Dr. Kumar, you want to add here? Or are any questions for audience on this, chest pain? And if patient is complaining of only exertional chest pain, so they are basically chronic stable angina patients. So there's no need to worry about it. It's not an emergency at all. But any patient complaining of chest pain at rest and showing these kind of symptoms, I think, so you have to, take care. And ECG, yes, helps only in classifying. Sometimes if you are not able to understand clinically, but if ECG is showing, ST elevations or ST depressions, again, you have to put that patient under ACS. Thank you, Dr. Shivsar. I think we'll move on to our next presentation on lipid management. Yeah, lipid management.
Thank you so much, Dr. Shivsar and panel, for sharing your expertise in ECG interpretation. Ladies and gentlemen, it's my pleasure to introduce our next speaker, Dr. Sandeep, consultant interventional cardiologist, who will enlighten us on the topic of lipid management.
My request to all the speakers, if you give, at least 5 minutes per discussion will be good for audience. Yeah.
Good afternoon, dear. A warm welcome to you all for this latest updates in cardiology scene. So, without much ado, I'll get into this topic. Lipid management, which is beyond statins. But before starting my topic, I would like to say, despite the topic is beyond statins, the statins form the pillar or the first line of management for the lipid management. Okay, so how important are statins? I would like to say with this picture. See, they are the pillar or the base. Okay, because they stand on the forefront of lipid management. Okay, so why statins? Why statins these days? So I will not go into this slide, but I will just try to emphasize as per this 2022 AHA guidelines. If you can see the patient subgroups, like patients with clinical ASCVD, very high risk ASCVD, okay, any patients with primary hypercholesterolemias, or any patients between 40 to 75 years of age with elevated LDL cholesterols, with diabetes, with any risk factors, any of these patients, if you can see on the other side, the first line of management stands to be the statin therapy. So I was using this word of ASCVD in multiple places, so I just wanted to show this line despite it's not related totally with our topic. So ASCVD risk calculator, this risk calculator, we can use it in our mobile phones. We have app as well as we can search in the Google as well. This really works in the clinical, in the OPD settings where we can risk stratify a patient of what is the percentage of risk. Thereby we can clearly show them, yes, this is your risk, that's the reason we are starting this therapy. Okay? So it uses this basic parameter, this HDL cholesterol, LDL cholesterol, smoking, age, and prior aspirin therapy, systolic blood pressure, and diastolic blood pressures. So why not statins? So if we're going to beyond statins, why not statins? So if you can see, statin-associated side effects, we have come across in OPD settings, clinical settings, where multiple patients in our OPD settings come back saying myalgias, new-onset diabetes, or even deteriorating renal function. And especially, most commonly we hear only two things. One is myalgias, and second thing is diabetes. And hepatic function decline, cognitive function decline is seen in few elderly patients. But frankly, these are all case reports. So what's the evidence? Yes, we have multiple RCTs clearly showing that all these complications are rare or very infrequent. Yes, and more interestingly, there is a trial, Samson trial. They have studied statins as well as placebo group, and they have clearly showed that even in the placebo group, in the statin group, the myalgias were 1.5 to 2%, whereas in the placebo group, despite no statin intake, there was incidence of myalgias of 0.5 to 0.7%. Thereby, we can understand how much the statins myalgia is widespread even across the general market. So, if not statins or along with statins, what are the newer agents which we are going to discuss? We know estimate is a gold standard drug. We have seen this since long. Bile acid sequestrants, PCSK9 inhibitors, bempedoic acid, inclisiran, evenirumab, and others which are not in the day-to-day foray, or the niacin and fibrates. So also we'll have a small understanding about what our Lipid Association of India guidelines recommend. These are from the recent 2023 guidelines. So they demarcate into low risk group, moderate age risk group, high risk group, and very high risk group. So let's not get into total details of it, but basically I will say low risk group, the LDL cholesterol target should be less than 100, non-HDL cholesterol, the target should be less than 130. And so on with the moderate, also it falls in the same category, but with few optional findings where multiple CVD or multiple CVA and CVD are associated, then we need to put the target as less than 70. So this slide clarifies most of the previous slide findings. So if you can see the risk categories, low, moderate, high and very high risks, okay, are clearly shown the risk factors, okay, and thereby what should be our lipid cholesterol, what should be our target lipid levels. And also the major ASCVD risk factors, the age, family history of CAD, low HDL cholesterol, high blood pressures, and smoking. So I would try to get into the newer management molecules. So in the first case scenario, let's see, this gentleman is a 42-year-old gentleman who is a known diabetic, smoker, comes for follow-up. He has no active cardiac symptoms, denies any cardiac symptoms, does regular exercise, and he is on atorvastatin 80 milligrams already for his dyslipidemia. And now he comes with a lipid profile report of total cholesterol more than around 240, and with the LDL cholesterol 102. So with this LDL cholesterol 102, we can assume that the non-HDL cholesterol in this case is 202, because non-HDL is 240 minus HDL cholesterol, that is 38, comes to 202 non-HDL cholesterol. So if we remember the previous slide, so the non-HDL cholesterol more than 130 is a significant risk factor, and LDL more than 100 in this case, both are risk factors. So how should we go? In this particular case, mind you, in this case we have no established CAD till now. So if you can see here, this patient falls under high risk group, that is one risk factor, and it has 3 ASCVD risk factors. So our target LDL cholesterol should be less than 70 in this case. So what is the first line of choice? My first line of choice would be estimate, because estimate is a gold standard drug. It has been studied over a decade, and it's indicated in primary hyperlipidemia, mixed hyperlipidemia, and homozygous familial hypercholesterolemia. The dose is 10 milligrams once daily. So the mechanism of action, if you can see, this is Niemann-Pick cells present in the breast border of the intestine. Usually they help in the absorption of the cholesterol, and estimate blocks that, thereby reducing the LDL cholesterol absorption. So the mean reduction in LDL cholesterol is, with monotherapy, estimate alone is 18%. When you add with statin, there is an additional 25% incremental reduction in LDL cholesterol. In few cases, elevated hepatic transaminases were noted, as well as myopathy and rhabdomyolysis have been reported in very few cases with estimate. Improving trial, which was done in around 18,000 patients, has compared in post-ACS patients with and without diabetes between the two groups. That is, one is estimate group, the other is estimate with simvastatin group, and it has clearly shown that there is significant reduction in case of recurrent ACS, that is recurrent ACS, recurrent MI, revascularization risk has significantly combined, all the significant risk has come down when estimate was added with simvastatin. Second case scenario, so this gentleman is a 52-year-old with the post-PTCA, that is, so established coronary artery disease, already on medications of atorvastatin 80 and estimate 10 milligrams. Now again comes with a similar lipid profile. So where we can see that LDL cholesterol is 1 or 2 in this case, and with the same subtraction we can estimate that the non-HDL is around 200. So are the lipid values acceptable? Anybody from the audience, are the lipid values acceptable? Yes or no? No. No, thank you. So if not, then what is the next line of treatment? So previously I said estimate is the next line of treatment following the statins. Now we have already used estimate in this group, so what will be the next line of management? Of late, 2 molecules have come and established in our Indian market. One is the PCSK9 inhibitors. Okay, they are injectable molecules, and the other is of recent, it has come, that is bempedoic acid. Okay, so let's see what is this PCSK9 inhibitor. So PCSK9 inhibitor, this is a small slide if you can see. It binds to the PCSK9 molecule and increases the number of increases the number of LDL receptors available to clear the circulating LDL cholesterol. Normally, what happens in normal PCSK9 molecule, it aids in reabsorption of the LDL receptors with the LDL cholesterol. Whereas PCSK9, what it does is it increases the number of LDL receptors over the liver cells, thereby decreasing the LDL cholesterol in the mainstream. So FDA has approved 2 molecules. One is evolocumab, the other is alirocumab. Alirocumab I have not added in the present discussion, just being that it's not much available in the Indian market. So we'll see about evolocumab. So evolocumab is usually given in patients with established ASCVD, also homozygous familial hypercholesterolemia cases. And the dosages being 140 milligrams subcutaneously every 2 weeks or 420 milligrams once every month. And it was shown that the mean reduction after with 140 mg is 64% and 420 mg subcutaneous is 58%. So this is a 4-year trial which has studied around 27,000 patients, roughly around 27,000 patients were studied in this 4-year trial. The patients were known established CAD patients, and they have concluded that among patients with elevated cardiovascular disease risk along with statin therapy, Raidurgam clearly shows was effective in reducing the adverse cardiovascular events. Now we go to the case scenario 3, where this gentleman, a known case of CAD, already on atorvastatin and estimate, also has a deranged lipid profile. So, since I directly go to the last person, that is, since the lipid profile is deranged, so now he says that he refuses any injectables. As discussed in the previous case scenario, PCSK9 is the drug of choice in this case, but when the patient refuses any injectables, or again if he is not affordable, because PCSK9 injection, it costs, the 140 milligram injection costs around 20 to 22,000 rupees per injection. So if he is not affordable, then what will be the next line of management? Here comes the new drug, that is bempedoic acid. So it was established in cases with ASCVD and heterozygous familial hypercholesterolemia, whereas PCSK9 was suggested in homozygous hypercholesterolemia. Bempedoic acid can be given in heterozygous familial hypercholesterolemia. The dose is 180 milligrams per day, and the adverse effects being hyperuricemia and tender nausea. If you can see here in the cholesterol metabolism chain, okay, so what happens is the bempedoic acid inhibits this ADP citrate lyase enzyme, thereby reducing the LDL cholesterol production. And when it is used as a single drug, it causes 24.5% reduction of LDL cholesterol. When bempedoic acid is used with estimate alone, not with statins, it causes an additional 15 to 17% of reduction of LDL cholesterol. And when triple therapy of bempedoic acid plus statin plus estimate is being used, the additional reduction of 38% of LDL cholesterol is being expected. So in the fourth case scenario, I will go into this gentleman who is a 48-year-old with known established CAD, with already on atorvastatin and estimate, both the drugs, and again having a deranged lipid profile. So any more drugs presently if we can use. So when he comes, and this patient particularly, he says, I don't want any more drugs. Already you are giving me, because you have to understand. Usually a patient coming with advanced cardiac disease or multiple risk factors, atherosclerotic risk factors like previous old CVA, hypertension, diabetes or smoking, or peripheral arterial disease. So he will be already in a list of drugs. Already if the patient again has LV dysfunction, he will be having 4 pillars of the drugs, which we all know. So when the patient is already on multiple medications and again he comes back complaining, sir, no more medications. Or when he refuses, says you're already giving to men, then what will be the last scenario? So in this scenario, a newer molecule has come up. Okay. This is inclisiran. What is inclisiran? It is a small interfering RNA. It's a small interfering RNA. It targets the PCSK9 molecule, inhibits PCSK9 production in liver, thereby prolonging the activity of the LDL receptors, and used in heterozygous familial hypercholesterolemia as well as ASCVD cases. The dose is 284 milligrams subcutaneous initially, and after it should be given at day 1, day 90, that is after 3 months and after 6 months. Thereby every 6 months one dose. Once in every 6 months is the dose. So definitely less number of injections compared to the bi-weekly injections of PCSK9 inhibitor. And the mean reduction in LDL cholesterol is very high, that is 48 to 52% period. So very minimal adverse effects like injection site reaction, arthralgia. But one thing is cardiovascular outcome trials are yet to be completed. It has shown significant reduction in LDL cholesterol levels, but cardiovascular outcome trials are yet we are awaiting, because the Orion trial and the Victorian trial is expected in the next 2 to 3 years. So just a small side, inclisiran and PCSK9 inhibitor, since both target the same molecule, that is PCSK9. So in this part, if you can see, this green, these are the PCSK9 inhibitor, that's the monoclonal antibodies. So they attach to this orange pieces, that's the PCSK9. And So thereby they inhibit the PCSK LDL receptors, over number of the LDL receptors absorbing the LDL cholesterol. Whereas this non-interfering RNA, this inclisiran, what does inclisiran do? See, this is an mRNA which processes the PCSK9 molecule. Now what is happening is, this inclisiran molecule has inhibited the mRNA. Thereby the PCSK9 molecules are not produced, thereby directly reducing the level of cholesterol. But no head-to-head comparisons have been done. However, LDL cholesterol load in response to inclisiran appears to be approximately 10% less compared with the PCSK9 monoclonal antibodies. However, the 2-yearly, that's twice-yearly administration of this injection is definitely a cherry in the cake for us. This is one more new molecule. I wouldn't go much into this because it's still in the phase 3 level. So this is an Ivanakimab, angioprotein-like 3 protein 3 molecule. It plays a key metabolism in lipid metabolism by increasing the LDL cholesterol and increasing the triglycerides. Now what happens is, loss of functional variants of this molecule has shown that there is a significant drop in LDL cholesterol, thereby reducing the CAD risk as much as 41%. So in the ELLIPSE trial where homozygous familial hypercholesterolemia patients were studied, there was a significant 47% relative reduction in the LDL cholesterol. However, cardiovascular outcome trials are yet to be studied, and the dose is around 15 milligrams per kg infusion, over 1 hour, once a month. I wouldn't go much into the management of hypertriglyceridemias owing to not much of developments, because these are all old molecules. So I would try to conclude my seminar by saying that patients with established CAD and presence of significant risk factors, therapy with lifestyle modifications and starting or non-statin therapy is highly recommended. So what I would start with is, so here this is the important thing. In patients with maximally tolerated statin therapy, or in patients with statin associated side effects where you cannot give any statins, estimate is the first drug of choice as per the guidelines. Following estimate, you can go with bempedoic acid or PCSK9 inhibitors based on the affordability, based on the compliance and everything. And if the patient is not compliant, just inclisiran. Why inclisiran in the last? Because each injection costs 1,20,000 rupees only. Okay, so drugs to watch for, Raidurgam in India, it is yet to be established. However, the guidelines have indicated in ASCVD cases, inclisiran, cardiovascular outcomes awaited, and Ivanakimab, cardiovascular outcome trials are awaited. Lumitapide is a new molecule to watch for. I hope these molecules don't make the interventional cardiologist jobless. It is I end my seminar. Thank you. Thanks for coming.
Thank you, Dr. Samdeep, for a nice elaboration on how to manage lipids, beyond statins. Let me ask you a couple of questions. So you have shown different patient scenarios where already statin was there.
Yes.
But my question is about a patient, a 40-year-old, no risk factors, non-diabetic, non-hypertensive, not a smoker, no MI. All the patients whom you have shown is, already had an established atherosclerotic disease, either in the form of coronaries or cerebral or peripheral artery disease. No evidence of, atherosclerotic heart disease.
Yes.
When to start statins for those patients? Because those are the common patients, who end up in, physicians' consultation chambers, right? So when to start statins for those patients?
As per the latest AHA guidelines, even from 20 years, we are recommending lipid management, lipid profile testing every yearly. And it should be every 3 to 12 months after initiation of any therapy. So once we started evaluation, and despite, as Sir has mentioned, there are no risk factors, we need to assess for check the levels of LDL cholesterol and triglycerides importantly. in this particular patient, if the LDL cholesterol is more than 100 milligrams per deciliter, then he can be kept on monitoring. At the same time, the triglyceride levels usually between less than 175 is the desired triglyceride level. Again, in this particular subgroup of patients, if there is any elevation of LDL cholesterol more than 100, or if there is very high triglyceride level, then we again need to go for further testing called, that is ApoB testing, ApoB lipoprotein testing. With considering all these three points into consideration, and if LDL cholesterol is higher and there is no family history and all, we can ask the patient for lifestyle modifications, and we can counsel them for a regular exercise, diet control, as well as follow-up.
So, I mean, broadly, if plain LDL level is beyond 190 in such patients, it is reasonable to, start statins despite there is no evidence of atherosclerotic heart disease. But if the patient had a history of premature coronary artery disease in the family, that means either a male member in the family got a heart stroke less than 55 years, or a female member in the family got a heart stroke less than 65 years, I think those are the patients where we go a little bit more aggressively, in treating with statins. After starting statins, when do you check for these enzymes for these patients? When do you again check lipid profile, and when do you check these enzymes as SGOT, SGPT, CPK to titrate medication, or sometimes to down titrate if it shows some adverse effects?
The enzyme should be checked after 4 weeks, that is 28 days after starting the statin therapy. And the lipid profile levels have to be checked every 3 to 12 months. Every 3 to 12 months. Lipid profile.
Yeah, I'll ask a similar situation where LDL is normal, only triglycerides are elevated. The elderly patient, no risk factors. And also, is it that SWBP is for triglycerides and statins are for LDL cholesterol? Is that true? Like, what I mean is, in some people's mind, if triglycerides are elevated, you should be treated with SWBP, and if LDL is elevated, statins. Is that true, or can they be changed?
No, sir. The statins have the high-intensity statins, something like atorvastatin and rosuvastatin, reduce the LDL cholesterol by as high as 50%. And they also reduce significantly the triglyceride levels. Whereas estimate also reducing the LDL cholesterol. But again, if you are seeing towards phenofibrates, then they particularly reduce the triglyceride levels, and to very minimal extent, they have an action on statins. Very minimal action on the LDL cholesterol levels. And you want an all-rounder, that is nicotinamide, that is niacin. Unfortunately, the drug has not been much successful owing to the side effects, multiple side effects, cutaneous flushing, gastrointestinal symptoms. And coming to your starting point of the question, that is triglyceride levels, how to deal with it. So what, as per the guidelines, 175 to 499 milligrams per deciliter of triglyceride should definitely make a clinician suspicious, and he should check for the patient's metabolic levels, that is if the patient is having any metabolic syndrome, diabetes, CKD, and he has to attend those particular things. And still, if the patient has any risk factors, then they should be started on first line statin therapy for that particular patients. And if there is no response, then we have to go to fibrates or niacin.
Just to add to that, the problem with triglycerides is that it's a weird paradox that elevated triglycerides have been shown to be a risk factor for coronary artery disease. But a reduction in triglycerides has not been shown to impact future risk of illness. That is why right now in patients who are asymptomatic with hypertriglyceridemia up to 400 or 500, there is no strong recommendation to start fibrates. And to answer your other question, no, it's not legitimate for triglycerides and statin for cholesterol, LDL. Both of them primarily target LDL.
Just to expand it further, So triglycerides, as Kumar said, there is no direct association with increased incidence of coronary artery disease. But people who has hypertriglyceridemia also have low HDL levels. That can cause increased CAD. But as Kumar mentioned rightly, so as of now, we are treating triglycerides only when it is more than 400 to 500. So anything less than 400, we just recommend lifestyle modification. And one of the good things with triglycerides is lifestyle modification itself reduces triglycerides significantly. The diet and regular exercise, it reduces significantly. Same thing is not true with LDL. It has no measured impact, with exercise and And the fibrates, yes, preferentially they reduce triglycerides. Statins they reduce.
One question regarding novel risk factors, HSCRP and the lipoprotein A. If they are high, then what are the cutoffs for this? When to start statin? And how it changes?
Despite lipoprotein A levels have been implicated in the atherosclerotic vascular disease, there are no clear-cut guidelines. So usually lipoprotein A level more than 50 is considered a risk factor, and when with a background of elevated CRP, then that is usually considered starting for the start of any statin therapy. But otherwise, as such, there is no clear-cut guideline. Only ApoB is being the study.
Okay. Thank you, Dr. Sandeep. In view of time, we'll move on to the next presentation.
Thank you, Dr. Sandeep, and our esteemed moderators for enlightening us on the topic lipid management. Please join me in welcoming Dr. Deya Vaswani, consultant interventional cardiologist, as she shares her expertise in hypertension management. What physicians need to know in 2024.
Good evening, Madam and respected chairpersons on the dais. Over the next few minutes, I will be taking you through a maze of BP cutoffs that are very important in different kind of clinical scenarios that we come across. So to start with, let's go on with the definition of hypertension first. So it is theoretically defined as elevated BP when an adult more than equal to 18 years of age comes with an office SBP of more than equal to 140 and diastolic BP of more than equal to 90 on repeated checks. So whatever data we'll be seeing today is as per the European Society of Hypertension 2023 guidelines and Indian Society of Hypertension 2023 guidelines. So they have defined a cutoff of more than equal to 140 by 90 to label a person as having hypertension. In India, in total we have 32.6% of the females and 38.7% of the males who have hypertension, but only 10% of all those patients are adequately treated. Remaining 90% either they are undiagnosed, untreated, or if at all they are treated, they are inadequately treated because they are not under proper follow-up. But hypertension, it is not such an easy game. We cannot ignore it as such because it leads to 10 to 12% of the total mortality that we see in the CVD patients. Overall, it is divided as primary and secondary hypertension, and assessment of overall CVD risk using various risk scores like ASCVD risk score, Family risk score, or these days the latest that has been described in literature is SCORE2 risk score. Calculation of this risk score for every hypertensive patient is very important because that will decide how aggressively to treat this patient. We know development of hypertension or BP control, it is a cascade of events. Environmental factors play a role, lifestyle factors including our diet, stress, alcohol, smoking consumption, genetic factors, all these factors, they come in collaboration and finally determine the level of BP that we go through in our daily activities. So this is as per ESH and Indian Society guidelines. Now, optimal BP is less than 120/80. Normal is less than 130/80 is defined as normal. High normal is less than 140 and less than 90. Grade 1 hypertension is BP of 140 to 160 and diastolic BP of 90 to 100. Grade 2 is 160 to 180 and diastolic BP of 100 to 110. And grade 3 is BP of more than equal to 180 by 110. Isolated hypertension, systolic hypertension, when the systolic BP is more than equal to 140 but diastolic remains less than 90. Diastolic hypertension, when the systolic is less than 140 but the diastolic is more than equal to 90. So all these are as per office BP recordings when the patient comes to us and we record. But after labeling a patient as having hypertension, how much is the patient supposed to have a risk of fatal CAD, CVA and CKD? So in all these factors, SBP remains a better predictor of these events in patients more than 50 years, whereas diastolic blood pressure is a predictor in young. And pulse pressure, which is actually an evidence of increased arterial stiffness, that is a marker, adverse marker in old age patients basically. And what is very important is increase in SBP of more than 20 and DBP of more than 10 doubles the risk of having a fatal CAD and stroke over a period of 10 years. So this is how important it is to treat the hypertension and as well as to bring it into the optimal control. So total CVD risk calculation is very important when a patient is being labeled as hypertensive. This risk score mainly involves sex, age, level of systolic blood pressures, smoking and non-HDL cholesterol. So this score basically takes into consideration the race, the age, the sex of the patient, and it gives us the overall risk estimation whether the patient is in low risk score, moderate or high risk score. Now risk stratification, as we think that it is more important in patients who have uncontrolled hypertension, but on the contrary, risk stratification is more important in patients who have high normal BP and grade 1 hypertension, because these are the patients who we do not start on medications, or they develop BP over a very early age and they are exposed to that high BP over a very long years in their life. So these patients, they have subclinical organ damage which is already going on, but we ignore these group of patients. Risk stratification is mainly important in these patients, because these patients, if the CVD risk is poor, we can just follow on lifestyle modifications. But if the CVD risk score is moderate to high, these patients should be started on medical management even on high normal BP. You have to include the pharmacotherapy in these patients. And in grade 2 and grade 3 hypertension, regardless whatever is the CVD risk, treatment should be started immediately with pharmacotherapy along with lifestyle modifications. So here we were discussing the grades of hypertension depending on the BP values. But there is something called a stage of hypertension also. Staging, it determines overall how much the patient's health is affected by hypertension. So stage 1 is uncomplicated hypertension, where the patient has not yet developed any established CVD or hypertension-mediated organ damage and includes only CVD stage 1 and stage 2. Stage 2 hypertension, where already hypertension-mediated organ damage has started. Patient is in CKD stage 3 or the patient has concomitant diabetes also. Then stage 3, where patient has established CVD and is in CKD stage 4 or stage 5. So we were just discussing about hypertension-mediated organ damage, what it is exactly. All the organs of the body, they are getting exposed to such high BP pressures 24/7. So it keeps on damaging the smaller blood vessels of the body and nerve damage keeps on happening on a subclinical level. So the main organs which are getting affected is heart, because heart is being subjected to increased workload and it will lead to hypertrophy and a variant of heart failure with preserved ejection fraction. Damage to the brain blood vessels, increasing the risk of strokes in this patient. As we know, high BP can cause ischemic as well as hemorrhagic strokes. Damage to the kidneys, to the eyes and to the blood vessels per se, leading to the development of peripheral arterial disease in these patients. So when we evaluate a patient with hypertension, we have to evaluate a patient whether there is already an onset of hypertension-mediated organ damage on the first workup of these patients. So this is a table which is showing CV risk as per the grade and stage of hypertension. So in this, we are considering the stages of hypertension as well, where the patient has another CV risk factors, has developed hypertension mediated organ damage, CKD and diabetes mellitus, and based on that, we risk the patient into low risk, moderate risk and intermediate risk. So both the stage as well as the grade of hypertension is important. Now, how to diagnose the hypertension? First of all, as per the definition, office BP recordings are recommended, in which at least 2 separate office visits should be there within 4 weeks. So 4 weeks apart, 2 readings should be more than equal to 140/90. BP in both the arms should be measured, and the arm in which the BP is more, that arm should be used for follow-up. And if the arm difference in both the arms is more than 20 in systolic BP, then we should evaluate for further causes of arterial disease in these patients. But in case the patient has grade 3 hypertension, that is the BP is more than 180, 110 on first presentation itself, then you need not have another office visit for this patient to start a therapy. Immediately you have to start therapy in such patients. Is presenting with symptoms of hypertension, symptoms of hypertension mediated organ damage or established CVD. In that case also, immediately start with pharmacotherapy. But in today's era, in 2024, it is not just about office BP. We have to measure out of office BP information also. We have to have that information because it adds complementary information to what we gain from office BP. So I am talking about home BP monitoring and ambulatory BP monitoring here. So this is a scenario recommendation for BP measurement at home and at office. So whenever the patient walks in, we have to relax the patient for 5 minutes. Do not measure BP immediately when the patient walks into the clinic. Relax for 5 minutes. He should sit comfortably. The arm should be at rest position. 3 readings should be taken, and out of that, first reading should be discarded, and the average of remaining 2 BP readings should be taken in this case. And whether the patient has taken any kind of caffeine consumption in last half an hour should be confirmed before taking that BP into account. So wait for 5 minutes after patient entry, preferably 2 BP recordings in both the arms, take at least 3 readings and average the last 2. Now coming to home BP recording. This means that we are having multiple BP recordings in the usual environment of a person. What person usually does in his day-to-day life. That means that the patient is devoid of white coat effect in this case. So the cutoff also goes down. In 40/90 now it is 135/85. So home BP monitoring, it helps in the diagnosis of white coat hypertension and masked hypertension. So masked hypertension, it means that the patient's BP was normal in office, but it is staying high during his home visits in day-to-day activities. So basically, why is this important? This is important because in this case, we won't miss out the white coat hypertension, the masked hypertension patients. And these patients, it helps us to predict the risk of developing hypertension-mediated organ damage, CV outcomes and mortality. So home BP recordings, they have a better correlation with the overall mortality than office BP alone. And it helps us measure day-to-day variability also, more predictable adverse prognostic marker. Now when to do? Home BP monitoring should be done at least for 7 days and it should not be less than 3 days. First day readings are supposed to be discarded. And every time when you are seeing the BP in the morning, at least 2 readings should be taken 1 minute apart. So the benefits of it are that we can assess the overall improved CV risk assessment in these patients. It identifies the phenotypes like masked hypertension and white coat hypertension, and long-term follow-up of improved BP control can be there. Suppose we started a patient on a medication, how is the medication working for that patient in his routine activities? That can be made out with this home BP recording. But on the other hand, the downside is, a lot of patients, they become anxious and they start leading to self-medicine modification without consulting the physician. They become their own doctors. It requires patient training, and lack of night BP recordings is the downside of this. So for this only, there is ambulatory BP monitoring. Ambulatory BP monitoring, it provides multiple BP recordings in conditions that reflect the routine daily activities and sleep. So the cutoff here is less than 130/80. This is 24-hour average of the readings. It also better helps us predict the hypertension-mediated organ damage and CV outcomes in mortality, diagnosis of masked hypertension and white coat hypertension, diagnosis of true resistant hypertension. And it is effective only when we have at least 20 readings during the day and 7 readings during the night and take an average of that, then only we can have an adequate average BP. So it quantifies 24 hours BP variability, and we can make out the nocturnal BP change in these patients, diagnose the patients with nocturnal hypertension which are at more severe risk, persistence of BP controls between the drug intakes, and daily hypertensive episodes. Let's say some patients they present with postprandial angina, postprandial hypertension or postural hypertension. That we can detect with ambulatory BP monitoring. But the problem here is it is not suitable for repeated use. Expensive and patient discomfort during sleep is also one more thing that we have to take into account. And one more important point is no RCTs are there to guide ABPM-based medications, even though it has complementary information to office BP, but just based on ambulatory BP monitoring, if we start the pharmacotherapy to the patient, is it really going to change the CV mortality or not? There are no clear-cut RCTs in that case. So overall, if we have to define the cutoff, office BP of more than 140/90, ambulatory awake mean BP of 135/85, a sleep mean BP of 120/70, and 24-hour mean of 130/80, and home mean BP recordings of 135/85. If the patient crosses these levels, it's labeled as hypertensive. So there are certain subsets like white coat hypertension where untreated patient with elevated office BP of 140/90, but 24-hour ambulatory BP stays normal. And awake BP also stays normal. Pseudo or false resistant hypertension when the treated patients with elevated office BP of 140/90 and 24-hour ambulatory is less than 130/80. Masked is the patient has a normal BP on office but has a raised BP on 24-hour BP monitoring. Masked uncontrolled means the same patient, it is a treated patient. He has a normal BP when he is coming to office, when he is coming for follow-up, but when he is doing his routine activities, at that time he has a raised BP on ambulatory BP monitoring. So office BP monitoring, this is for the diagnosis of the patient. When the BP is more than 140/90 low risk patients and 130/80 high risk patients, self BP monitoring, we have to subject the patient for self BP monitoring. If it is less than 125/75, no need to do anything, just keep the patient on follow-up. Repeat self or home BP follow-up every 3 months and ambulatory BP follow-up every 1 to 2 years. And let's say the BP is between 125 to 35 at that time, subject the patient for ambulatory BP monitoring. If the BP is more than 130/80, start antihypertensive therapy, perform again ambulatory BP monitoring, and if the target is achieved, continue same. If it is not achieved, then we have to change the antihypertensive. And if the self-BP monitoring is already more than 135/85, start the patient straight away on pharmacotherapy. Now, evaluation of the patient. Evaluation, we have to consider the personal history, risk factors, drug history of these patients, presence of any kind of symptoms, and history of possibility of secondary hypertension. To evaluate, we have to evaluate in such a way, especially if it is a young patient, whether there is already a development of hypertensive mediated organ damage, or if it's a young patient, to rule out the cause of secondary hypertension. Standard lab workup is equally important in these cases. So as per the CVD risk is concerned, ECG and echocardiography will start having changes of hypertension within 6 months of onset of hypertension, whereas carotid ultrasound and peripheral arterial disease, they will start having changes after 12 months. Now, when to refer a patient to a cardiologist? Patients in whom we are suspecting secondary hypertension, young patients with grade 2 or grade 3 hypertension, or patient with sudden onset or aggravation of hypertension when BP was previously normal, patient with treatment-resistant hypertension, that means on 3 drugs, out of which 1 is a diuretic, and need of more detailed assessment of hypertensive mediated organ damage, and hypertensive emergencies. Now, secondary hypertension. It represents only 5 to 10% of the overall patients. It is a frequent cause of worsening of previously controlled hypertension, severe or too resistant hypertension, and increased severity of hypertensive-mediated organ damage. And some forms of these secondary hypertension are more common in elderly, like atherosclerotic renal disease. All forms we usually see in less than 40 years of age. So classification, mainly the causes of secondary hypertension, either they can be endocrine causes or renal parenchymal diseases like polycystic kidney disease, CKD, or development of renal atherosclerotic disease, fibromuscular dysplasia, coarctation of aorta, collagen vascular diseases, neurogenic factors like sleep apnea, autonomic dysfunction and brain tumor, and consumption of drugs. This is for secondary hypertension. All of us are mostly confused how to work up this patient. So the workup, it mainly depends on, first you have to establish it is actually a secondary hypertension, younger age, presenting symptoms of the patient. Do a thorough physical examination, ask for the complaints, drug history. Considering all that in mind, then you have to think what can be more probable in this patient, and you have to start evaluating in such a way. Basic lab workup will give you a huge idea. Urine creatinine ratio, albumin creatinine ratio will give a huge idea in these patients. Now coming to the management strategies, recommended any guidelines, especially in high normal and grade 1 hypertensive patients, the first recommendation is leave the patient on lifestyle modification for 3 to 6 months. But do we really emphasize it on its importance? Do we really explain that to the patients? But all of it, they carry really good significance. Alcohol consumption, diet modification, it leads to fall in the systolic BP of as much as 6 mm of Hg and diastolic BP of 4 mm of Hg. This is how important it is, if you can actually explain it to the patient. So once the patient is diagnosed, how to proceed in this case? So in case of grade 1 hypertension and grade 2, if the patient is asymptomatic without CVD risk, at least one additional office visit should be done within 4 weeks, and if we have established the diagnosis, initiate on lifestyle interventions in these patients. And even after 3 months, if the patient is unable to control the BP and bring down to less than 140/90, we have to start the patient on drug management. But if the patient is symptomatic or has other CVD risk, in that case, along with lifestyle modification, start on medical therapy and aim for optimal BP control at least within 3 months. You don't want a BP control immediately. You can span it over a period of 3 months. So initial choice of drug, the main change that is there in these guidelines compared to other guidelines is the addition of beta blockers as the first line therapy. In previous guidelines, beta blockers was not there in the first line therapy, but now ACE inhibitors, ARBs, CCBs, thiazide like diuretics and beta blockers all combined into the great first line therapy. Start with dual combination therapy in most patients and then slowly up titrate to the maximal tolerated dose. If it is not getting controlled, then add to a triple therapy. It is always preferred to start the use of single poly combination at any step, because rather than starting a medication at full dose, we are giving the side effects of that drug also to the patient. So start with a low dose of a combination therapy, because in that case, multiple mechanisms will be adding to reduce the BP rather than only single mechanism. So start with a dual combination. Mostly the most preferred is ACE inhibitors, ARB with CCB, and thiazide like diuretic. Up to 60% of the patients will get controlled with the first single polytherapy, and if that is not getting controlled, then triple therapy with ACE inhibitors, CCBs, thiazide like diuretics. With this, up to 90% of the patients they get controlled if they are literally drug compliant and not truly hypertension resistant. Only up to 5% of the patients will be true resistant hypertensives, and in that case, we need to further evaluate the patient. Now coming to the management of hypertension in a patient who has already established CAD. So as we know, the first drug would be ACE inhibitors and ARBs considering the CV mortality benefit, and beta blockers in this case, because beta blockers, they help us control the heart rate also in these patients. And Despite that, if the patient has angina, then add dry hydropyridine CCPs because they have vasodilatory effect. So this will further help us. And if the patient is without angina, then we can consider using a diuretic also directly in this case. In patients with heart failure with reduced ejection fraction, in these cases, ARNIs may be a better choice further because they have an additional effect on BP monitoring and CV mortality as well. So first choice will be ARNIs, the 4 building blocks, adding a spironolactone, and after all this, if the BP is not getting controlled, then adding a calcium dihydropyridine CCP would be the last choice for BP control in these patients. Heart failure with preserved ejection fraction, the same therapy goes in, but in this case, starting a beta blocker early would be very effective, and an SGLT2 inhibitor has to be combined in heart failure with preserved ejection fraction patients. In stroke patients, hemorrhagic stroke or ischemic stroke. Basically, in these patients, we have certain patients might be eligible for going for thrombolytic therapy. So if the patient is coming with more than 220 by 120 BP, our target is to bring down the BP to less than 180, so that you can subject the patient to thrombolytic therapy. There is no sudden reduction of BP aimed in these patients. If the BP is less than 220, then you can slowly bring down to 140. But if it is more than 220, bring down to 180 first and then target 140. It is stepwise over several hours. In CKD patients, let's say CKD 1 to 3 stage, eGFR is more than 30, then ACE inhibitors and ARBs are first choice in 1 to 3 stage mainly because these drugs are known to reduce the proteinuria. Once they reduce the proteinuria, they come down to the CV mortality in these patients. And then CCBs can be added, and if it's a true resistant hypertension, then spironolactone can be preferred over other MRAs, and next step would be going for alpha-1 blockers like prazosin or doxazosine. Third, last step would be adding a centrally acting agent, that is something like clonidine. But in these patients, one more additional factor is adding SGLT2 inhibitors. In stage 1 to 3, SGLT2 inhibitors have an additional benefit in reducing proteinuria in these patients. So we spoke about the drugs, but what is the target that we are aiming at in different subsets? In CAD patients, therapy should be started when the BP is more than 140/90 and the target BP is 130/80. But in elderly patients, we do not keep a very high target, very close control. That is because in these patients, the patient might be having the side effects of the drugs more often and features of hypovolemia would be there. So in elderly patients, the target would be less than 140/80 and a less strict target is there in CKD patients. In CKD patients, 140/90 BP is also acceptable. Now coming to the management of hypertension mediated organ damage, proteinuria is one very important risk factor. So for every hypertensive patient, we should do urine microalbumin to see the amount of proteinuria and then immediately start them on ACE inhibitors and ARBs. And we should aim to start spironolactone in these cases. Resistant hypertension. Resistant hypertension means when a seated office PPO is more than 140/90 on 3 or more antihypertensives at maximally tolerated doses, and one antihypertensive is a diuretic. So it will account for only 5 to 10% of antihypertensive patients, and 50% diagnosed as resistance will have pseudo-resistance in these cases. Either they will be drug non-compliant, or the BP would not be measured properly, or suboptimal dosing would be there. Screen for causes of secondary hypertension in these patients. And after all 3 drugs, 4th drug we can add hydrolazine with a beta blocker and diuretic effect in these cases, add MRAs in these patients, and after that also if the BP is not controlled, we can substitute minoxidil, and after all the efforts, if the BP is not controlled, subject the patient to renal denutrition therapy. Next is hypertensive urgency versus emergency. BP pressure control escalating to more than 180/110. Evidence of target organ damage, and the patient will have symptoms and signs of headache, chest pain, palpitations, dyspnea. And in these cases, pharmacotherapy can be initiated But in hypertensive emergency, there is damage to vital organs. There will be neurological deficit, signs of heart failure or papillary edema will be there. These patients need to be admitted and given IV therapy. So in these scenarios, the BP target would be malignant hypertension, reduce the mean BP by 20 to 25% over several hours. The drug of choice would be leptalol and nicardipine. In ACS, immediate reduction of BP to less than 140 should be the target, and the drug of choice would be nitroglycerin and labetalol. Acute cardiogenic pulmonary edema, immediately reduce the BP to less than 140, and the drug of choice is nitocloside or nitroglycerin. Aortic dissection, immediate BP reduction to less than 120 with ismolol or nitocloside. So coming to the conclusion, these are the major differences that we are seeing in the guidelines today. The hypertension definition has again been increased to 140 by 90, and normal BP range is less than 130 by 85. And the hypertension has again been divided into 3 grades, which were divided into 2 grades previously by the ACC guidelines. And beta blocker is included as the first line therapy. And I would like to underline the importance of ambulatory and home BP recordings in patients, not to miss the hypertensive patients, and start therapy as early as possible. Thank you.
Thank you, Dr. Daya, for a comprehensive, cover of hypertension. Only this time, we ask our audience to come out with questions. If you don't have questions, we'll put. Any questions from audience? Yeah, please. Quick. One, please stand.
Yesterday, I have seen one patient whose BP was 240 by 140. Actually, that patient has gone to a eye specialist for blurring of vision in one eye. So the eye specialist has diagnosed macular hemorrhage. So he has come to me today. I refer to cardiologist, but how to manage?
Yeah, I think the first thing is it an emergency or not? That is what, I think if patient had hypertension with a macular hemorrhage, it is a hypertensive emergency. So what I had already showed, hypertensive emergency means those are the patients where you have to reduce the blood pressure to your target level within 1 hour. That's how we work on those patients. So any hypertensive emergency, high blood pressure like what you said, with a macular hemorrhage or with a stroke or with angina, angina or with renal failure, those are the patients where we consider it is an emergency. We reduce pressures to target within 1 hour. So for that we generally use IV nitroglycerin, that is one drug which can be used. Another is labetalol, IV, based on the preference in that particular patient. Along with that, you have to start vasodilators, what they already mentioned, like calcium channel blockers or AT2 receptor antagonists or ACE inhibitors with IV diuretic, which potentiates the action of other drugs. You start all the drugs and you have to enhance your NTG every 5 to 10 minutes, because peak effect of NTG comes within 5 minutes. So after that, whatever the dose you are giving, the effect will be same. So you have to enhance your NTG dose every 5 minutes, 5 to 10 minutes, till you achieve your target level. So targets are not same as what we target in a regular patient. Targets can be slightly higher also. It need not be 140/80 or 130/80. Often we keep generally it is measured as 1/3 of systolic pressure, or reduction is minimum which you have to achieve. If you come to 140, it's fine. Otherwise, at least 1/3 of systolic pressure should come down, or you can come to around 150 systolic pressure. I think that's an emergency what you talked about. Any other questions?
Good evening.
regarding the establishment of the diagnosis, you said like 3 readings should be taken and 1 first reading should be discarded and the rest 2 should be taken. But if like in a clinical scenario or if we are working in a government setup, in that case, like with that huge number of patients, those many readings, is it like technically possible, or like how should we manage that thing so like we can get to the diagnosis?
I think one quick answer for your question is, see, you can recommend you put patient into his care. That is home BP monitoring, right? That is something probably, I think that should be the louder message, from this platform. So home BP monitoring is something which can be used, which can be done by patient who can do his recordings, which already, they are mentioned. Probably you can discuss, offline with them. So how to record, there is a pattern how we have to record. So ask the patient for next 4 to 7 days, record his blood pressures and come back with the whole data. Based on that, we can take decision. That becomes much easier for you. But one question that I see, the patient is there in their OPD and pressures are, let's say, around 140, 150, 95. And they measure twice, as you already suggested. Do you want to start, in which patient do you want to start therapy immediately? In which patient you want to still wait and recommend either home BP monitoring or ABPM?
Sir, if the patient is coming that way, so first we have to see, is he having any kind of symptoms? The remaining profile of the patient, is he already a diagnosed case of, let's say, CKD, has a diabetes, has already dyslipidemia or any kind of CAD? In those cases, I would directly start therapy. Because they are on moderate to high CVD risk score, then no point waiting. But if that is the first time that the patient has come, at that time I would send the patient for the remaining profile. Let's do an ECG, let's do a 2D echoes, do a simple lab profile of the patient, see the creatinine, albumin levels and potassium levels. After seeing all this, I'll ask the patient to come back again within a week, within 4 weeks with all those reports and then decide whether I should start or not. And meanwhile, I'll also explain the patient to do the home BP recordings. That would be the most appropriate way.
So thank you there. But sometimes we also see patients, I have, experience of patients where you see the pressure is like 180, 110. And you already mentioned, when it is stage 3, you start therapy immediately. But patient was absolutely asymptomatic. And he never had any recording before which showed abnormal. So how to approach those patients? Because often I do either home BP monitoring or ambulatory blood pressure monitoring for those patients. At least in my experience, there are 2 patients whose blood pressure was always normal when they are out of hospital.
So they are all out of hospital if it is normal, and hospital it is 180, 110, and again comes masked hypertension, sir.
Yeah, it's kind of white coat hypertension basically. So, generally we think, white coat hypertension may not show like 180, 200 pressures, but I have seen, in my experience I have seen. So, though it is stage 3, if some patient denies that his pressure was never out of range when he measured at home, I think those are the patients where we can be cognizant of their data and we can wait to start medication and just recommend a home BP monitoring or ambulatory blood pressure monitoring before you initiate therapy. That's what I practice, because the moment you label patient as hypertensive, start therapy, it is like a curse. It is like lifetime.
No, 180 by 110 is always risky. So better to start at least on 1 drug and then let them do home BP monitoring, and then we can de-escalate and then we can label it in reverse way also.
Sir,
because
white coat hypertension, no guideline says that start with the therapy straight away. You have to take patient status into consideration.
It's a reasonable strategy to go for ABPM and home BP monitoring before taking a decision which is going to affect the patient for lifetime. So that we have to
There's no consensus to start trial straight away, sir.
With one more point, probably we'll close this session. See, once you started therapy to these patients, we should always recommend, come back with home BP readings after 1 week, done after 1 week. So we should understand the peak effect of drugs which we are going to start today, the oral drugs, the peak effect comes after 4 to 5 days, not immediately. So, if patient checks his pressure every day, that is not going to be useful. There is no point in stepping up therapy, every second day. So ask the patient to come back with home BP readings, which he has to start after 5 to 7 days from initiation of therapy. And for almost like what I have mentioned, minimum 4 to 7 days of home BP monitoring. And based on that, you have to titrate. So it's like you can ask patient to come every 2 weeks till his pressure comes under control. I think with this, we end this session, so we'll move on to the next session.
Thank you for your attention.
Thank you, Dr. Thea Vaswani. I would like to extend a warm invitation to Dr. Sridhar, Consultant Interventional Cardiologist, Medicover Hospital, to come forward and delve into the topic of MI Islam.
I hope you are having a great time. The previous speakers have already set the bar high. So I'm Dr. Sridhar. I'm a consultant cardiologist at Medicover Hospital. I'm an interventional cardiologist with special interest in preventive cardiology. Not by choice, but by some amount of force. So I say force because we in the Hi-Tec city encounter a lot of young patients. Being in the IT territory, we encounter a lot of patients who present with vague chest pains. They Google up the symptoms and they come with a lot of questions, asking that, is this chest pain a heart attack, or I am going to die out of heart attack, or doctor, recently one of my friends had a heart attack, so I am going to have the heart attack, or my family member had a heart attack. So these are the various questions they put on. So I have no choice just to assess his history and predict whether he's going to have a heart attack or not. And it's just that I can only assess his risk, but don't have a definite answer. So my topic today is risks, CAD risk stratification, the beyond traditional tools. Traditional tools you already know. So the problem is huge. Cardiovascular disease is one of the important causes, most important or number one cause of mortality, that is death. This is our own data. So this is our own data. So number of people who are dying out of cardiovascular disease is 272 per 1 lakh population. This is way beyond the global average, which is 235. That means more people in India are dying out of cardiovascular disease. And the problem is compounded by the fact that we Indians have cardiovascular disease 10 years earlier, and the atheroma burden, that means amount of atherosclerosis, is very high, and we have a typical triad of low LDL, low HDL, and high triglycerides, which is different from the Western population where they have very high LDLs. Second thing is we have more amount of the risk burden, traditional risk burden, that is more number of diabetic patients are there. Our country is diabetic capital now, and the truncal obesity. Also in the recent trials, the levels of lipoprotein A homocysteine Asian population. So we need a tool to assess the risk or chance of having heart stroke, so that we can take an early step, early intervention, either pharmacological or non-pharmacological, so as to prevent CVD. So I'll start with a case, a typical anxious software employee. He comes to me. Basically, he has habits, but he anxiously told that his young brother had an MI and underwent BTCA last month. He's absolutely asymptomatic. His other vitals, BP was normal, slightly overweight. So he came with all the investigations. The HbA1c was normal. So only thing was, LDL was on the little higher side, 172. Mind you, he is 45 years. So he even came up with an ECG also, which was normal. So what should I advise him? How do I assess his CAD risk? And does he already have CAD as his brother had? So these are the questions which were in my mind. So why we have to assess CVD risk? Because like any other disease presents with symptoms, but CAD is one thing which can present with sudden cardiac death. So there is a data which shows that sudden cardiac death and acute MI as an initial, acute severe MI as an initial presenting almost 62% of the times. That means these people don't give us a second chance. They just collapse. They are absolutely asymptomatic earlier, but they just collapse after having an MI. So we need to have a tool which can predict such kind of events. So are there any risk scores? So we do check for cancer screenings, we do pap smears, we do mammograms, we do PSAs for cancer screenings, but being a number one death cause, we don't have any other tools to assess or predict the cardiovascular risk. We generally don't use, actually doctors are not aware of these tools. There are many tools available, Framingham's, ACC pooled cohort study, Raynaud's score. So these are already available. All these tools, they provide what is the chance of you having a heart stroke in next 10 years so that an intervention can be started. So you don't need to mug up all the scores, you just have to get comfortable with one score and you apply it in your patients. So Framingham's risk score is one of the earliest and very basic risk score. So the Framingham, if somebody is aware, Framingham is a small town near Massachusetts, America, with this almost 6,000 patients. Generations after generation, that means 3 generations have been followed up. All the risk factors, cardiovascular events have been picked up and this risk tool has been generated. So you just enter this age, gender, lipid parameters, you end up having a risk. The risk generally is below 10, low risk, 10 to 20, intermediate risk, and more than 20, you are high risk. So one of the drawbacks is that it overestimates the risk in low risk population. That means it is difficult to apply it in young population, and also it overestimates the risk in elderly populations. So there are these underestimation and overestimation are inherent to this risk stratification. So if you are aware, disease is because of interaction of our genetic makeup with socio-economic and environmental factors called risk factors. These risk factors lead to these diseases. So if you have to prevent the disease, there are 3 varieties of preventions. One is primordial prevention, that is you act before emergence of risk factors. That means you start lifestyle before onset of diabetes, before onset of hypertension. And primary prevention is once you have risk factor like hypertension and diabetes, you treat them to not for the heart disease or a stroke to happen. So these are the 2 areas which are interested when compared to my interest of my topic. So what are these risk factors? As you know, there are many risk factors which can be divided into 2, modifiable and non-modifiable. As you know, non-modifiable age. So any patient with elderly male, I'm sorry, this cannot be modified, this cannot be changed. And in any woman post-menopausal state have the risk same as in any elderly male. And familial dyslipidemias and a strong family history of premature disease. These are the risk factors wherein we cannot change things. But there are other risk factors like hypertension, diabetes, dyslipidemia because of our food habits and smoking habits. So there are other set of risk factors like obesity, sedentary lifestyle, unbalanced diet, and psychosocial stress. These are called predisposing risk factors. That means these risk factors will lead to these diseases. So it is difficult to quantify them and put it into risk predictions. So sometimes a pregnant woman with history of DH or gestational diabetes also carries an increased risk of cardiovascular disease in the future. So always in a female you ask for this history, pregnancy-induced hypertension and GT. So in addition to these risk factors, there are some novel risk factors. Even during my PG days there was buzz about this, but now there is a lot of data about contribution of these risk factors to the CV disease. So of them, CT calcium score, lipoprotein A, HSCRP, apolipoprotein B and A1 and the ratio, homocysteine level and carotid intima thickening. So these do not have incremental value in predicting the disease, but they can be complementary to your traditional risk. So out of this, the lipoprotein and calcium scoring, CAC scoring, they are of most value to the current risk factors. So when should I start assessing the risk? There is a polarizing view. So most of the data shows that we should start assessing the risk after 20 years of the age. That is the age when atherosclerosis has its onset. If you look at the pathology drawings, atherosclerosis has its foundation at 20 years of the age. So you should start assessing the risk. There is some data which tells that if you start assessing at 20 years of the age, you tend to overestimate, you tend to overtreat. So though there is a polarity, but there is a subset of patients who have a very strong family history of premature CAD, that means they have a blood relative who died of heart attack or who had a heart stroke at 30-40 years of age. You should start assessing at 20 years itself. Other risk factors are if the patient is already diabetic for more than 10 years, even if he is 10, you should start assessing his risk. Or if the patient is smoking. So what you should do, you just have an interaction, you assess his smoking status, assess his dietary habits, assess his level of physical activity, ask for history of premature CAD or sudden cardiac death in the family, you measure his BP, you measure his waist circumference, measure his BMI, and test for a baseline lipids and diabetes. So once you do these things, how do you go forward? As I told you, there are many risk scores. What I am familiar is this one. ACCHA is CBD risk calculator. All these risk scores are now web-based and app-based. They are available in your phones also. You just have to open and mention all these parameters: age, male, weight, BP, systolic BP, total cholesterol, LDL, and whether the patient is on any drug treatment. Mind you, this is only for primary prevention. That means those who doesn't have any atherosclerotic cardiovascular disease. That is, doesn't have any heart stroke, brain stroke like that. So this is a typical example I have put. A 45-year male, normal BP, normal cholesterol levels, non-smoker, non-diabetic, patient is non-hypertensive, it's not on treatment. Typically you get a value of 1.8. So that is, it tells you what is the risk. It is low risk. So same patient, you add smoking to the same patient, the risk increases to 4.7, close to intermediate level. You add diabetes to it, the increases to 8.9. So these are the high risk, intermediate to high risk patients. So it tells you the risk. Also, it gives you an advice what you should be doing. This patient who is diabetic smoker and has a 10-year risk of 8.9, you should immediately start him on statin, high dose or moderate intensity statin. So our case, as I told you, I have put all those things, the young chap with the family history, LDL of 72, the risk score came out to be 4.5%. He fell into the low cardiac risk. But, so as usual, he persisted on evaluating further. So I had no choice but to order on the list of other tests, novel risk factors. I ordered lipoprotein A, CRP, calcium scoring. His calcium scoring was 0, but surprising was that his lipoprotein A levels were 130. So which is considered another novel high risk factor. So subsequently I had to start him on the drugs. So after you work up these things, typically these patients fall into this spectrum. One is low risk, that is less than 5%, intermediate risk 5 to 20%, high risk more than 20%. So this is typically a low risk candidate. He looks like this, no history, asymptomatic, normal BPs, and as a cardiologist I would be happy to see angiogram like this. All the vessels are normal. So this is typically low risk, that is less than 5% chance of him having a heart stroke in the next 10 years. This is high risk group. Already these patients have an MI or a CVA or has a diabetes or has an LDL more than 180. Already it's being discussed, any LDL more than 180 is considered a very high risk factor, and irrespective of the age, irrespective of him having a disease, each patient should be started on a statin. So these low risk and high risk patients are very easy because low risk is low risk, you don't need to treat him. High risk is already a high risk, he is already on all the drugs. You just need to optimize the drugs. So the holy grail leaves you with intermediate risk patients. These are the patients who have 1 or 2 risk factors and his CV risk is around 5 to 20%. So here comes the role of novel risk factors. You can further risk stratify such kind of patients with novel risk factors. So one of that risk factor is CAC score or CT coronary calcium score. CT calcium score basically identifies the calcium deposits in the coronary artery in a plain CT scan. Earlier it was used to be done by electron beam CT, which is a very cheaper and low radiation CT scan, but right now they are all being replaced by multi-detector CT scans. Typically, a CAC score requires 1.5 millisieverts. So one risk of getting CT scan is exposure to radiation. So one has to keep it in mind that we are getting exposed to radiation, chances of cancer increases. So this is the amount of radiation typically we have. So it is equivalent to almost like 150 times in a single X-ray. So if you are getting a CT scan, that means you had 150 number of X-rays. That is the kind of radiation we are exposed to. But typically it averages around 0.8. So generally it is reported as Eggertson score after this gentleman, Dr. Arthur Eggertson, a radiologist who came with the concept of calcium score. So any guesses? This is a CT scan of one patient. You can see this white chunk. So this is what we say calcium within your coronary arteries. This is LAD. So some aware physicians can go forward and say that this is a calcium, there is a calcium in LAD LMCA. So typically that means there is some amount of atheroma in your main vessels. Yes, the pictures talks it all. So a calcium score, more the calcium, more is the chance of having a heart stroke. So a patient who has 10 to 100 to 400 calcium score has 4-fold risk of getting a heart stroke. 400 to 1000, 7 folds. A patient with more than 1000 has 10 folds, even goes to an extent of 27-fold higher chance of you having a heart stroke. So having calcium score, does it really indicate chance of heart stroke, yes, there is a lot of data on calcium scoring. It is the best tool to assess subclinical atherosclerosis over any serum markers for prediction of future cardiovascular events. So why not? Because it gives such beautiful pictures of atheroma. You can see a small narrowing also, stenosis also. So more data. You can see patient, the yellow line, patient with 0, when followed up for 5 years, he stands a chance, a very low chance of cardiovascular events. I'm sorry, the patient who has, and patient who has lot of calcium has very high risk of developing stroke in the next, in the coming times. Also, there is a study which compared a patient has 3 or more risk factors. So he was subjected to CT scan. A patient with more risk factors with low calcium still has very low risk of cardiovascular event risk when compared to a calcium score more than 300. So overall, elevated calcium score, it increases the risk. Same thing. Events are low when you have 0. The event rate is almost 0.2 per year. Have a calcium. When you have a calcium score 0. Again, comparison between a calcium score and diabetic duration. So we think that more the duration of diabetes, more we are at risk of heart stroke. In such subset of patients, also, even in patient who has diabetes for more than 10 years, if he has calcium score 0, the chance that he will have high events are very less. So, so does calcium score 0 predict that you don't have a stenosis? So this is the registry from Denmark, which showed that in patients with 0 calcium score, chance that he will have a significant obstructive plaque is very, very low. So when you have a 0 score, you are reassured. Chance that you will have a heart stroke is very, very low. So people ask, particularly Indians, they ask for a warranty for everything. Okay? Do you have a warranty for anything? So now we have a investigation which has a warranty score. If you have a 0 calcium score, if you follow up this patient tends to have this calcium score 0 for the next 6 years. That means you don't need to repeat a calcium scoring for next 5 years. You can ask the patient come after 5 years. Even with diabetics also, the calcium score tends to remain 0 for almost 3 years. So a calcium score 0, patient can be reassured, sent back and ask him to call after 5 years. So does calcium score help in reclassifying in a group of patients with intermediate risk? When calcium score was added, so there were 63% of patients who had 0 calcium score. That means the intermediate patients who were advised to have statin, 100 patients who were advised to have statin, 63% patients fell into a low risk group where there was statin use can be ruled out. So again, it can reclassify the patient with intermediate risk score. If the patient is in intermediate risk score, you do a calcium score. If it is 0, you don't need to put them on statins. If it is more than 0, you can recommend statin. So also, it motivates the patients. As I said, a picture is worth 1,000 words. When you have a calcium chunk on your scan, CT scan, and if you show it to the patient, chance that these patients comply with the medication and lifestyle changes is more. So with this evidence, now the guidelines also say class 2A recommendation. That means it is reasonable to perform CT scan in patients who are at intermediate risk. That means has 2 or more risk factors. You do a calcium score, and if it is 0, you can always reassess the patient afterwards and control the risk factors. Same way, in patients with intermediate risk score, you don't need to put them on statin, you can reassess after 5 years. But if the calcium score is 1 to 99, it is reasonable to start statins. If the calcium score is more than 100, it is class 1 indication to start statins. So, what are the uses of CAL score? In intermediate risk patients to reclassify, in those patients who are statin intolerant to put them on other class of drugs. Whether the patient is really at risk, you can do a calcium scoring. Sometimes it helps you in decision making in starting and even aspirin also. And in evaluating the patient who comes with a recurrent low risk chest pain. And as I said, it can be used as a motivational tool. CT angiography, I don't want to talk much about it. It's a gatekeeper in patients who have a high calcium score that is more than 100 or more than 400. To know the severity of the stenosis, we generally do a CT coronary angiogram. But for the primary risk stratification, we generally do a calcium CAT score, that is CT coronary calcium score only. Sometimes CT angiograph is useful in low risk patient. A young patient comes to the emergency, has a typical chest pain, so we rather than performing an angiogram, we generally perform a CT scan to rule out a stenosis. So conclusion of CT. So the power of zero calcium score reassures you that he is at low risk. So other risk factors, the lipoprotein little a is a new tool. It's basically a LDL particle. 1 in 5 has high lipoprotein. In addition to atherosclerosis, it also is implicated in aortic valve calcification and aortic stenosis. It is highly atherothrombogenic. So its level is predetermined by genetics. Its level is less influenced by lifestyle. Our patients have very high levels. So yes, it is proven to cause increased risk of atherothrombosis. Generally, the guidelines say you check the lipoprotein little once in your lifetime. It tells you whether it is high or low. So recommendation is you just treat the other risk factors. The other latest drugs are coming under the research. So basically, HSCRP is another tool which tells you in a patient with already risk factors, it tells you whether the patient is at risk of acute coronary events. Basically, it is an inflammatory marker. High amount of inflammation suggests that there is a high chance of cardiac events. Last few slides. Cardiovascular disease, statins are known to prevent cardiovascular disease by 25% per year. So they are the only tools right now available. So we need to predict it. We can use the risk factors. Sometimes, if the risk tools does not give you any answer, you can always fall upon these novel risk factors like calcium scoring, lipoprotein little a.
And take the questions for both speakers together at the end of the session.
Thank you, Dr. Sridhar. Without any further Balaji, Senior Consultant Interventional Cardiologist, as he discusses the management of cardiac patient management.
I think the grade should have been little cut up now. So I will take a little short presentation, mostly with some case studies. We all know that the cardiac patients cannot come back again to the primary cardiologist. Majority of the patients, they go back to the physician in their village and town after having their treatment done, intervention done, or surgery done. And for generations, physicians has been managing these patients very well with their updated knowledge and also the clinical acumen. And on that background, we study a few of these patients, some case studies kind of thing, and how to make a physician makes a difference when they follow up these cardiac patients. We start with a post-valve replacement patient. We all know that now valve replacement is the end of a disease and the beginning of another disease, where the patients with the mechanical valve, they require a lifelong goal-line either with a warfarin or a comedy. And we all know that the INR has to be maintained in a tight range so as to be effective. Otherwise, valve may clot or they may bleed. So let us see that let's say that if patient has seen two patients on a single day with a mitral replacement patient having a INR of 5.5, the INR for a single valve replacement mitral is 2.5 to 3.5, and a double valve replacement patient MVR and the AVR has a low INR. So how do we adjust the warfarin dose so as to bring back the INR to the ideal range? So there is a simple rule called as 10-20% rule. So you try to add on the 1 week warfarin dose, and then either you decrease or increase the warfarin dose by 10 to 20%. For example, the DVR patient has been taking 20 milligrams of warfarin, so 10% of 20 milligrams, 2 milligrams, and 20% is 4 milligrams. You have to 4 milligrams to the 20 milligrams and adjust the warfarin dose. It's 3 milligrams in 5 days and 5 milligrams 4 days. That becomes almost like 24 milligrams. This is how we increase the warfarin dose so as to achieve the ideal INR. Similarly, in the MVR patient who has a higher INR, we have decreased by 20%. Again, this patient is taking 30 milligrams, so 6 milligrams is 20%, decreased by 6 milligrams and make it 24 milligrams. This is how you adjust. If INR is very high, try to hold the warfarin for a couple of days and then restart by 10 to 20% rule. If it is significantly high, so we always have a referral center in Medicover. We have 3 centers in Hyderabad, so you can go to one of these centers. We have a 24/7 cardiologist and a good the blood bank facilities. These are very interesting patients. These are all patients whom I have seen, I have interacted, and I have referred, or I have not diagnosed. This patient came recently, tiny, 30 years old, 26 weeks pregnancy, has been on following drugs. I have not seen this many drugs being taken for a pregnancy-induced hypertension. If we could have that, 20 mg/kg, 60 milligrams, Lipid 200 milligrams, 2 TAD, 1600 milligrams, Hydergam tablet. It comes as Atrial, APR is well. It's a very good molecule for a resistant hypertension. Very high hypertension is not controlled with regular medication, especially with CKD patients. BP control is difficult. Atrial is one of the choice of a nephrologist. This patient is taking Hydergam 25 milligrams, again 2 tablets, 6 thoroughly, almost like 200 milligrams. And the BP, despite this kind of medications, continues to be 160 by 100, and she recently developed bleeding of it. So, do we have any other medications beyond this? Let us discuss the good, bad, and ugly of pregnancy-induced hypertension medications. The good is alpha-methyl-dopa. Most of us don't see nowadays in the pharmacy. They're not very effective. Lipid can be given from 100 milligrams to 400 milligrams. This patient is receiving already. If it is 100 to 60 milligrams, the patient is receiving already. Hydergam can be given from 25 to 250 milligrams. The bad is beta-blockers and high diabetics. The beta blockers are bad, basically they can cause fetal bradycardia. Hypertension can cause maternal hypovolemia and hypertension. So these are not given, but they can be given. And luckily, of course, recent beta CRPs, they do a renal dysgenesis of the fetus, so they are not going to give. So with these drugs being taken already, so can the audience say what else we can do? Increase hydrogen. We have already received 200 milligrams, but 50 milligrams difference, does it make any difference? Okay, I too was perplexed. Actually, I did not know what to do. So the patient, thought this doctor cardiologist has no answer. So she went back to her native place, Raidurgam. She went to her local, we have the family physician. So all the physicians are very intelligent people, and those physicians with gynecology by far nature as well. I mean, it's richer with knowledge. So he called, the physician called his wife, and it's her real name. I have a patient whose cardiologist is not able to treat the patient anymore. She is 26 weeks pregnant, and then she's a primary, and she's 30 years old. And these are the medications for her. He said, why are you breaking your head? The doctor does not know. She has simply assessed the fetal maturity, the induced rapid labor, and sent a neonatal care. So this physician was perplexed. Oh, does it happen like that? Then you deliver at 24 weeks. He said, we have a hospital called as Medicover hospital, where they have delivered 50 grams delivery at 2 weeks less, 24 weeks. This happened in 21, in 2022. Under 24 weeks pregnancy was terminated because of the hemorrhage, and this fetus has survived with the 710 milligrams. So in our case, we have sent the patient, we have reduced labor and delivered by electricity resection, and the child has made a great recovery. So what I want to say that sometimes we may have to think about what's happening in other specialties. Like in this neonatal care, I never know that we have certain good neonatal care, and until the gynecologist in Hyderabad told me. Mr. R, I prescribed Mr. R a clopidogrel aspirin combination. I did him coronary angioplasty, a very tough angioplasty, as the name would say, late bifurcation, calcium, iron ventilation, and all. 3 years ago, I almost spent 3 days without sleep because there was some issues with the calcium breaking and all. And after 3 years after the procedure, he came to me. He's going to America, and then can you go? So I said, okay, clopidogrel aspirin, all protein medications you take and go home. And he came back from his. I thought, he would get me some gift, some chocolates from USA, but he came with a legal notice. You know what he said? He is going to Consumer Forum for 1 crore compensation against me. What was the allegation? He went to America, I had upper GE bleed. 20 units of blood transfusion was given. With great difficulty survived and came back. The doctor in America said, who is this cardiologist? He was giving the real antiplatelets to you 3 years after PLC. We all give only 1 year, and sometimes we give only for 6 months. So let us see the evidence, what evidence says regarding the DAPT versus SAPT. Mr. R. Son is a pharmacist, and he downloaded some literature also. So actually this is all what he downloaded and sent to me. So he has sent from Journal of American Heart Association and Journal of, and then a Lipid Heart Journal, and there is journals which all says the same thing, So beyond 12 months, DAPT may not be necessary. Extended DAPT did not achieve severity reducing the net adverse clinical events. The use of virantiplatelet appeared longer than 12 months in patients with their received ventricular stent was not significantly more effective than single antiplatelet, and all the more, our friends there is no apparent benefit but instant harm. With these, he went on to Consumer Forum. So luckily for me, the consumer forum, the judge asked for the complete discharge summary and luckily for me, American people did not give me anything. His own allegation was there no records, so I escaped. So 1 crore saved. But let us see whether what does the literature says. Literature says that so this is ACC, and ASC guidelines. They say that the DAPT can be given in ACS patient with no high risk bleeding up to 12 months, 1 BR, and 2 BA up to 30 months plus. So this patient is probably justified in giving a DAPT innovation. Basically, what we see that when we are giving a DAPT or SAPT single antiplatelet in a post-PCA, we see the ischemic risk versus the bleedings. If you did a ACS patient, distillation, MIA, we did a complex PCA, bifurcation lesion, left main lesion, aspiration, multiple stents, probably are justified in beyond 12 months, but not in a single PCA. We also see for the risk of bleeding. If the patient has a high bleeding risk, like a frail patient, elderly, hypertension, and then has a bleeding risk, probably you can stop in 6 months. On the contrary, if has developed a thrombosis, then we have to probably extend for more than 2 years. Most of trials have done 30 plus months, and most support trials that are up to 5 years. So the lesson is that in case you see a patient post-PTCA, DAPT after 5 years, please withdraw one tablet, give only single antiplatelet. Otherwise, you may also face the visit that I have faced. Or after say 1 year, probably you may not give dual antiplatelet. So with the current generation, third generation drug-eluting stents, so only in the ST elevation MI, you have to give 12 months of DAPT, whereas in chronic coronary syndromes, you can give 3 months or 6 months. So also non-elevation MI, 3 months or 6 months is 2A recommendation. So this basically I want to say that DAPT, extended DAPT probably may not be warranted, and then sometimes patients may end up in bleeding and then probably may play worse. Very interesting case, another interesting case. Again, I did not die in this case. 43-year-old female, married, Diabetes. She developed a central retinal artery occlusion left eye. She went to ophthalmologist, ophthalmologist said go to cardiologist, get echo done. Cardiologist did echocardiogram, no F, no LA clot, no LV clot, no MI, no MVP, nothing. So he was given some kind of aspirin. What does we do? Even aspirin and say, okay, some kind of drops and all that. She's after 3 months, she comes to me with a DVT, deep veins thrombosis of left leg with pulmonary embolism. Like if I had pulmonary embolism, massive. And she came out 3 to 4 days after the pulmonary embolism. We gave some heparin followed by the apixaban. But I was perplexed. Why? There is a CRAO and then there is a DVT. At that time, we did what is called as prothrombotic state. We checked for a prothrombotic state by factor C as protein C deficiency, prothrombin gene mutation, factor V mutation, and thrombin deficiency. So all these things became negative. So I was not sure that what we are dealing with. So we also know there is a Atrial syndrome, anti-phospholipid antibody syndrome. In women, if they develop any thrombosis, please be aware of this syndrome. Ask the woman whether she had multiple abortions, whether she has children or not. So this Atrial syndrome is very important. It's very common in our practice. It's only when you are aware of this Atrial syndrome that you can diagnose. Otherwise, you miss these patients, and the patient may develop different thrombosis at different places and then have a high mortality rates. They develop a deep venous thrombosis, pulmonary embolism. They can have phenomenon, and they can have microexplosive CRAO, CRVO, tailwind thrombosis, and these things. And that this patient is ablation. She's Aliparas, she had at least 1 abortion, and she had developed a CRAO DVT, but twice done prothrombotic profile and apply antibodies on it. So I don't know what to do. And compounding my problem, rubbing salt to the wound, after 6 months after the pulmonary embolism, she came with heart failure symptoms. First time I heard a murmur, mitral regurgitation murmur, tricuspid regurgitation murmur in her, which was not there. It was from normal except for little higher PA pressures at that time. The PA pressure has come down, and then she was doing very well. Now she has got an MR and here. I don't know what to do. So she had a heart failure. So, and compounding that, the echocardiogram showed some vegetations. The valvus metal valve with a visitations. There is no history of fever, blood test is negative. So it's called a non-bacterial endocarditis or Lippmann-Sachs endocarditis. Now the problem is how it will different. Once the heart failure, started for heart failure, got better. We need to understand that now how much you may treat with the 4 pillars of treatment. So there is always a residual risk. So when you may develop with the arm, there is a residual risk. You may treat with the DAPA, there is a residual risk. So it may decrease from 50 to 11, 22, but there is a residual risk. That's what you need to know. The 4 pillars are not very everything. In our patient with 4 pillars, he has become contributed. So there is one trial which was done called the Victoria trial, where the patients who are stable to decompress, these patients were recruited 5,000 patients, and they are divided into 2 groups. One group was given Versiguard, and then another group was given placebo. And this trial, the primary endpoint was received in the group which was taken Versiguard and compared to placebo, and the combined endpoint of first heart transplantation death has increased. And then with the other restriction of 4 points, it reduced to 10%. So Versiguard is a very good drug when there is an acute decompression chronic heart failure patient. So it has an impressive number to treat. 24 patients treated for 1 year to prevent 1 mortality. It rivals with any other medications. Whereas Hypertension was some 37 patients treated 1 mortality. 19 patients were empagliflozin repair, 27 patients were metoprolol. So it's an impressive medication. So the patient got better. He didn't have another hospitalization, but the patient came after 4 weeks with the blood pressure of 100 and a heart rate of 90. So do we have any other medication beyond this? That's what? Yes, we have SHIFT trial shows that 6,000 patients symptomatic heart failure less than 30% still with heart rate of more than 71. Evaporatin is being given. It also decreases the heart failure hospitalization and combined mortality. So this patient ultimately went for along with 4 pillars of treatment. The patient also was given Versiguard 2.5 mg only, which was increased every 2 weeks to 10 mg once daily, and evaporated 5 mg twice daily. And the case, 6-year-old male, again this happened to me around 20 years ago, 25 years ago, when I just started my practice. A 6-year-old male, constant diabetic, at which 25 years ago, had a viral pneumonia, and was subsequently, when he came with the heart failure symptoms, he was having lung dysfunction. So it was diagnosed viral myocarditis and heart failure. So I used to go to long ago Siddipet. This is my Siddipet patient, a still rebirth patient. His name is Pandaya. So I diagnosed him as viral myocarditis cardiomyopathy heart failure, treated him, and then he said, no, is there any remedy? I said, most of the viral myocarditis patients with the direct LV may not survive too long. So this patient apparently went under doctor. The under doctor did an angiogram, found out 3 vessel blockage. The patient underwent a bypass surgery. got better, his LVF improved. And he came back to me, he said, doctor, he said, while my birds, I had a pulmonary disease, CBC diagnosis. He is so proper person in Siddipet, so it happened that whenever I go to Siddipet, anywhere, somebody used to say, sir, you did not diagnose properly. He said, while myocarditis, he seems to have bypassed it, he was doing that. Sometimes he used to come to my work and sit outside. He don't believe this doctor does not know how to diagnose. He missed my diagnosis. These are the really happened. So these are the hard things, which you learn in life and you never probably do that kind of mistakes. But I meant to say that when you see a cardiomyopathy patient, you also always think about reversible causes. Ischemia are one of the reversible causes. We know that cardiomyopathy, alcohol, stress-induced cardiomyopathy, this can happen in the post-operative ward as well. With hypertension during managing the patient in the post-op state where the anesthesia gives a lot of material marble, that can also be possible. Tachycardia cardiomyopathy, both hypothermia can cause airway dysfunction, reversible, sepsis, reversible, acute, and chronic kidney dysfunction can reversible, nutrition deficiencies, thiamine deficiencies, reversible, sleep apnea, reversible, rheumatic heartaches and all that, these patients will undergo surgery, they are reversible, the collagen, the SLE, reversible. Lot of sarcoidosis tuberculosis can cause myocarditis and reversible, hemoglobin reversible, amyloid. So please understand what I told this basically is that we need to be aware that whenever we see a cardiomyopathy patient, don't write it off. Okay, this is the terminal, we have a high, 5% mortality, 50% or 75%, only 4 pillars are there, 2 additional pillars are there. So we need to probably each and every patient think about a reversible cause. Another LVCU SOB, male 55, hypertensive, came with class 2 SOB, echo was normal. The axis investigated by PFT, CTC, HRCT, nothing was down. You notice LDH by ECG and repeat echo, and then this patient has the so-called diastolic dysfunction. So, heart failure with reservation fraction is not uncommon. We all are aware of this condition more and more. A stiff, thick, and heart, heart muscle with a low EF, preserved EF and compared to low EF, can cause heart failure symptoms. The issue, most of us, when you don't have a clue about a heart failure, some patient comes with heart failure symptoms, you don't have to try to do this antiprotein. It's a very, very sensitive test. Very sensitive test. Recently also I saw one of the very senior, pulmonologist treating one patient of cardiomyopathy as COPD for last 2 years. Since still his EF became 10 to 15%, he was hospitalized with shock and pulmonary edema. So if a simple antiprotein would have probably changed the diagnosis. So this patient had a diastolic heart failure. Diastolic heart failure is a very complex pathology from the myocardium to the aorta, the capillaries, and they have inflammation. I don't want to go into details. So we all know that now in a forum like this, one of the patients beautifully said, what's the treatment of FF? He said, weight loss and weight loss. So weight loss seems to be the treatment, the lifestyle modification, the treatment, and also the treatment of comorbidities like fibrillation, the volume overload, these things need to be taken care of. Yeah, sure. So another elusive SOB is this male, 55 years, who comes with me with all investigation for no SOB, no relief, no diagnosis. Okay, it's their mind. So I wanted him to open his mouth and show. He may not show the holiness like Lord Krishna, but we are supposed to see the soft palate and uvula, and this magam part is core. We know that in this patient, so nothing is seen except the big tongue. So this patient basically has a sleep apnea. Sleep apnea is a very interesting condition. Sometimes I diagnose more of sleep apnea than CAD in my OPD, and I'm thinking whether I'm cardiologist or a pulmonologist. So this has a very daytime sleepiness. Sometimes they deny daytime sleepiness. They snore only partner knows, and so we need to ask partner that he snores. And then headache, weakness, all these things we all know. So these things are real. One of my cousins who did research in Chennai, he used to sleep while driving. His wife used to sit with him and keep seeing only his face. And his blouses, he says, get up. He used to get up. So luckily he survived almost like 4 or 5 years sleeping behind the vehicle, and then we recently gave the CPAP and he is doing well. So the treatment, of course, is weight loss, CPAP and BiPAP, operated surgery. Pharyngoplasty is can be offered to some of the patients with maxillofacial issues. Maximum amount of advancements are available in our hospital. We have Sampurna Ghosh who did a couple of cases of me where the maximum amount of advanced one patient of pharyngoplasty, the patient are doing well. And this patient underwent a sleep study, my patient, whose tongue is Hasi, and the AHI was 64, and he was resuscitated during the night time. Resistant hypertension, the patients who are taking maximum standard medications, you know, for example, the patient is taking the diazepam, 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 these are 3 medicines you have tried. And still the patient with BP is more than 140 or 90 called resistant. Most important, please remember, the whole drug is alactone. Not beta blocker, not after beta blocker, not any of these medications. These are all afterwards symptoms. So the drug, the 4th drug, most importantly is alactone. Remember this, not giving alactone properly, we are not doing justice to these patients. Chest pain, not always CAD. One patient, one obese female came to me with epigastric lower abdominal chest pain, and then I have a habit of doing ultrasound of the abdomen. I screen for gallbladder stones. These are gallbladder stones. In the last 4 years, I have diagnosed more than 5 lab polycystitis patients, and I have diagnosed 2 CA esophagus. Recently, I diagnosed one CA lung. So what I meant to say, once we need to somehow, the cardiologist has to down the role of physicians, we need to think out of the box. This visual I am going to see, you will remember your life. I can bet it. A teenage boy comes to me, 18 years old. You are seeing the chest physician, he is seeing for chest pain with the cardiologist. Cardiologist will go into cath lab. The patient comes. The person who brings the patient has a very great, value about the cardiologist. Sir, my cousin, just see him, he is having chest pain. The doctor was going to cath lab. He said, hey, 18-year-old boy, what we have? Get easy code and put him back. He comes back. This man again, when he comes back with this man again going to cath lab. So such a busy cardiologist, not so busy. So they both are alarmed. He said, oh, take antacids, get lost. So the patient has this one. He has xanthelasma, tendon xanthomas, pendulous xanthomas. I never see this. It's almost like an apple stage on his buttock. You know what it is? These are all cholesterol, tendon xanthomas. This patient, LDL, do you know how much it was? 520 milligram deciliter. The first time I have seen, he has a familial hypercholesterolemia. So he underwent angiogram at 80 and underwent bypass. The latest age familial hypercholesterolemia underwent bypass is 13 years, 13, not 18. My patient was elderly. So we have diagnosed criteria for familial hypercholesterolemia. The heterozygous is very common, 1 in 250. Homozygous is uncommon, 1 in 3 lakh. And regarding the avlogamab and the inclisiran, Dr. Sandeep has told already. So this I rest my case, and thank you very much for it.
Thank you, Dr. Balaji sir. Same humor, same humility, and nice presentation. As Dr. Balaji mentioned, often we cardiologists end up in a impasse in defining, some patient scenarios. I also refer patients to physician to have a second look on the patient, because for a cardiologist, the mind is, it's like a telescope. So you always think about heart, whatever patient is saying, you try to connect with the heart. I think often it is useful to send the patient to physician. They come back with some new thought and new ideas. Or I think we'll move on to the next presentation. I request speaker. Yeah, next session. So we move on to next session, and I think probably can.
I would like to thank all the esteemed speakers and moderators for this informative discussion. Let's break for high tea and reconvene in 10 minutes for part 2 of the seminar, where we will guide you to the world of interventional cardiology, electrophysiology, heart failure.
See, we continue the session, right? Whoever wants to grab tea, you can grab.
Yeah, bring it in. So,
pull next panelist.
So our next topic is intervention inviting moderators, Dr. Bharat Reddy, Consultant Interventional Cardiologist, Medicover Hospital, Dr. Balaji, Senior Consultant Interventional Cardiologist, Medicover Hospital, to come on the dais for this segment. I also invite Sridhar sir and Krishna Prasad sir to come on the dais. I now invite Dr. Damodar, Consultant Interventional Cardiologist, Medicover Hospital, to join us on stage and shed light on the topic optimizing PCI, new generation tools to improve coronary stenting outcomes.
Good evening everyone. I'm Dr. Damodar, Interventional Cardiologist from Medicover. With the completion of breathtaking session by Dr. Balaji sir, we'll be going to next session starting with basics of intervention and also the new tools in cardiology. So I'll give a basic just of how the coronary supply is. Heart has two systems, coronary, left coronary and right coronary. What you're seeing is left vein dividing into LAD and circumflex, and this is right coronary artery. This is a normal angiogram. But coronary angiogram is a traditional imaging modality for visualization of anatomy and guidance for PCI. However, it's a two-dimensional luminogram, and we cannot get the complete information regarding the stenosis or the block morphology. And further planning of any complex or intermediate disease, you need other modalities to go forward. So what are the modes for optimizing PCI? So there are three approaches, and this mechanical approach which we are going to deal with, the other glucometabolic approach and lipid approach already has been discussed. So coming to the mechanical approach, improvements in revascularization technique with intracoronary physiology, that is FFR, and improvements in revas technique with intracoronary imaging. There are two imaging modalities, that is intravascular ultrasound and OCT, that is optical coherence tomography. And improvement in device technology, how to deal with difficult block morphologies, what are the new tools to deal with. So this angiographic severity of stenosis, you are seeing mild coronary artery disease with 20 to 40% of block here. And this is intermediate stenosis with RCA with 50% stenosis. We call it as intermediate, 50 to 70% of the block burden. And this is a critical stenosis, proximal RCA 95% stenosis. And this is inferior MI, we presented with 100% total occlusion of right coronary artery. So just to have understanding of the coronaries and severity of stenosis. So mild CAD, generally we go with medical therapy. With moderate coronary stenosis, will be a little difficult task to deal with. That's the reason we need other modalities. And more than 70% stenosis, definitely we revas the patient with stent or CABG. So moderate coronary stenosis, we need more refinement to take decision. So regarding the physiology, in angiogram, what you are seeing is structure of the coronary tree, but is the stenosis causing a significant flow restriction distal to the tract? That is been evaluated with fractional flow reserve. And intracoronary imaging, as I told you, by IVUS and OCT, these are complementary to coronary angiogram, which helps us in decision making. So two fundamental questions to be answered while performing a PTC or stenting: is the lesion significant and ischemia producing, and should it be treated? And if at all we are treating it, is it properly optimized or not? So coming to the functional strategy, that is fractional flow reserve with intermediate stenosis, that is 50 to 70% of the stenosis. Is it a significant flow limiting disease? We have to take decision by doing a fractional flow reserve. Here we put a guide catheter and put a pressure guide wire here and check the pressures distal to the stenosis and proximal to the stenosis and take the ratio of that. So we'll get a ratio between 0.6 to 0.9, and above the 0.8 we put it as negative FFR, and less than 0.75 is very significant, and between 0.75 to 8 is we call it as again gray area in FFR. So this is how we do, this is the area of stenosis, and we pass the pressure wire, check the pressure here which automatically takes the average, and it's an hyperemic index because with maximum vasodilatation we do this test by with infusion of adenosine. So as I told you, more than FFR, if the intermediate lesion having a FFR value of 0.8, definitely stenting can be deferred in that scenario. So coming to the case-based scenarios, it's a 65-year gentleman from Mahbubnagar with chronic diabetes and hypertension, came with shortness of breath 15 days with ECG echo normal and treatment test was positive. So this was his angiogram. This is a left coronary tree, and you can see there is some kind of 50 to 60% stenosis in the proximal LAD. Being significant symptoms with the TMT positivity, we need to further take decision, should we defer stenting or to take a decision to stent this vessel. We need other modalities. So in this case, we did a FFR for this patient by placing the pressure wire across the lesion here. This is LAD. So we got the pressure tracing with the value of 0.97. 2 times we have taken, and we taken the average. Definitely it is negative FFR, so definitely we need not stent this patient. So we have sent this patient for medical therapy with statins and antiplatelet therapy. So case 2 is a 62-year-old male with no coma with stable CAD, again TMT positivity, and he has TVD with other 2 lesions are significant, but LAD was intermediate disease. So proximal LAD, you can see a block here, and it's around 60 to 70% lesion, but distal LAD is significant. So in this case, should we stent or not? We did a FFR again. Here the value came around less than 0.8. So definitely it is significant with 2 values coming below 0.8. So in this case, again we set with imaging with IVUS, which calculate mean luminal area, which come as 2.9. So definitely FFR and imaging showing significant LAD disease. So after distal stenting, we did a proximal stenting also. The final, we have done the FFR to see a good functional flow. So it came to be post 0.9. So coming to the next modality, that is coronary imaging. After the functional significance, next we go to coronary imaging. There are 2 modes of imaging. One is intravascular ultrasound and OCT. So because angiogram gives limited information, so we need to go inside the coronary tree and look for plaque distribution and extent, vessel remodeling, plaque composition, stenosis severity, reference of the well size if you are stenting, and post PTCA, how is the stent expanding, and post PCA complications. So this is a intravascular ultrasound console. This is a catheter which is sent inside the coronary tree and image the vessel like this. This is a normal coronary artery cross section. This is what we see in the IVUS. So this is a cross section of the IVUS image. So this is the intima, media, and adventitia. If the patient has plaque, it encroaches the lumen. So this patient has diseased coronary artery with, this is a block, what we are seeing here. And you can see this is a concentric block, this is an eccentric block, only towards one direction. So this information we got with the intravascular ultrasound. These are various block characteristics which can be seen with IVUS, which cannot be seen exclusively in the coronary angiogram, which helps in decision making, that is types of characteristic of the block. So last one is the thrombus, which you can see here. So calcium appears as white in the IVUS. So whenever you see white image and the rays doesn't cross this white image, then it is a calcium. So this is another modality called OCT. It's a contrast to IVUS, which gives orange image compared to black and white image of IVUS. So in our institute we are predominantly IVUS operators. So we'll more of discuss with the IVUS. So IVUS pre and post PDCA should ask some questions. There is a lesion significant, understand plaque composition, and we have to prepare the lesion if at all there is some calcium and fibrous tissue. And we have to decide on stent sizing depending on take the diameter and length also according to IVUS. So this is a case of angiographically you can see this LMCA is a catheter which is showing significant stenosis. See, we have taken a IVUS full back. So in the IVUS we get areas of 7.27 with clock of around 50%. So more than 6 in a left main with around 50% block area, we can definitely defer the stenting. That's the reason we have deferred stenting and put him on medical therapy. If we didn't have any IVUS in this case, I would have stented the LMCA in this case. So IVUS has prevented me to put a stent in this patient. So we'll go in a case where primary PCA was done a month ago to RCA and later admitted for staged PTCA to LAD. So LAD you can see there proximally it looks not very tight, intimate kind of lesion. But IVUS gives a lot of information in this case. So this is IVUS pullback. How we see the block here. So a lot of calcium. And this is the minimal lumen area with significant calcium in this. So such kind of patients requires newer tools to cut the calcium. In this case we used a rotablation or rotablation which drills the calcium and cracks it, and after that we put a stent across. So this is a rotablation which will drill the calcium and shave the calcium out, and later we dilate it with balloon with good cracks in the calcium. We did a stenting later. So we have answered all questions. Lesion was significant. We understood there is calcium, and we adequately prepared the lesion with the IVUS guidance, and we have taken appropriate stent sizing. So post PCA, this was the result. You can see how beautiful the artery is, and we got good areas post PCI. I was considering the IVUS areas. So post PCI optimization, we have some criteria, but in view of time, we try to skip it. And what are the other improvements in device technologies after our functional and IVUS? So a lot of interventions challenges are high thrombus burden and calcium and fibrous tissue. So thrombus, if there is a lot of thrombus, initially there was traditional thrombus aspiration technique, but recently we got a good tool in our cath, that is laser, excimer laser coronary angioplasty, which evaporates the thrombus and prevents the slow flow. So this patient has RCA with whitish appearance, this big amount of clot sitting in the mid RCA. So next, what are the other challenges is the coronary calcium. So calcium is tough thing to deal with for interventionists, so we also come with good tools to operate and give optimal result with the new tools. So you can see this lot of calcium in the lady. This is IVUS with calcium, and this is OCT picture showing superficial and deep calcium. So these are the different tools we have in the cath lab. So this is called angioscalp balloon, which have blades spiraling around the balloon. This is a cutting balloon having blades on the balloon, which helps in cutting the calcium. This is lithotripsy balloon, which sends the shock waves and tracks the calcium. This is orbital atherectomy. It's a new modality next to rotablation, so which helps in drilling of the calcium. And this is a LCA laser, which helps in using in ACS thrombus condition, also non-crossable calcified lesions. So this is a case scenario where acute anterior MI, patient presented an angio was done in outside center with LAD total occlusion, where they attempted wiring, but because of the calcium they could not wire it and could not attempt, they failed completing the PCA, and they referred to Medicover. So this was his angiogram. You can see LAD, there is 100% occlusion. It should be like this, and you can see there is sheet of calcium in the yellow border. So this is the path of LAD, and you can see straight away a lot of calcium sheet along the vessel. So he came with a low blood pressure and Phillips 2 class with minimal basal crepes with intermittent chest pain. So we have to take him for procedure. So this is a current procedure we did. So this is a LAD with thrombus and calcium. We wired the LAD And later, we have since patient has severe LV dysfunction, we don't want any blood clots going into microcirculation by using thrombosection. So we did with laser. So this is a laser catheter which we are sending into the LAD. So this is the IVUS information with a lot of thrombus and also associated calcium. So laser second pass we did it to increase energy, and later we did a IVUS. And next we had to use lithotripsy below. This is a shockwave lithotripsy which outside in the cath lab, it gives such kind of shocks in the coronary tree to crack open the calcium. So we did IVL next to crack the calcium. And post-IVL flow is completely established, and we completed the BTCA with good final result. So next is in a periphery center, Dr. Intervention underestimated the calcium. The patient presented with inferior wall MI. He has placed RCA stents almost 1 week ago with underestimating calcium on the angiography. So he landed up, stent could not expand it. Then later he presented with again acute inferior MI with stent thrombosis. So the left coronary, there is LCX disease, but culprit was RCA. This was our presentation. You can see RCA is totally occluded. But you can see this is the stent which was placed and it is underexpanded because the calcium bed was not prepared by the first interventionist because he did not use coronary imaging. So initially a lot of thrombus was there with did thrombosection. We got a little flow. We tried to balloon open the vessel, but it was hard calcium because again it was reclotting. We did an IVUS. You can see significant amount of calcium with stent under expansion. You can see this is the area. There is a various cut section with stent under expansion in this segment because of calcium. So next what we did was we used lithotripsy balloon. This is a balloon which gave almost 80 pulses. In spite of that, calcium did not open. So next we have to use rota ablation. This is the rota. So we did rota also for this patient. Since the cath lab is equipped with all modalities to handle such kind of cases, this is the case we used almost all modalities to open the stent. So after that, still it was under expansion was noted. We used a high pressure balloon called OPNC balloon. And after this so much of valiant efforts, the stent got opened up and calcium got cracked, and we placed 2 stents in the mid to distal RCA and 4x28 stent in the proximal RCA, and this is the final result. So these are final IVUS areas which is adequately dilated stents. So adequate learning from this case would be adequate block preparation in the first sitting is very important, because once you put the stent with unexpanded calcium, uncorrected calcium, the next intervention would be very tough, which we experienced in this case. So coming to beyond angioplasty, also we have to manage the lipids and also glucometabolic events, so that next risk of restenosis will be less. So we should think beyond optimize PCA followed by maintain good metabolic and lipid management is important. And I want to introduce another topic called ultra low contrast, zero low contrast PCA, which we routinely do in our center. We land up all the CKD patients are at high risk for coronary artery disease. Patients on dialysis, definitely, since the patient is on dialysis, in spite of having contrast nephropathy, we can dialyze the patient. But we come across patients having 2 to 3 creatinine levels, not going on to dialysis, with presenting with multivessel CAD or having the ACA situation. So such kind of patients, if you give contrast and do a PTCA, definitely they will be going on to dialysis. So such kind of patients, to avoid contrast, with the help of IVUS imaging, we can make the contrast so minimal as and so that to prevent patient from going on to dialysis. So this is a routine PCA what we do. So it's a RCA 100% block. We open with thrombosection. So this is a thrombosection catheter. We are sucking out aspirating the thrombus. The lesion has opened and we have put the stent. This is the final result. We got a beautiful result, but the problem is we used 80 ml. This patient with normal creatinine value, so we didn't have an issue. But how to deal with patient with high creatinine? So this was a patient who presented with infraposterior MI, and this is the left system with 100% LCX stenosis. So patient creatinine of 2.5 with EGFR 28, and the peripheral center, they were not equipped with IVUS imaging, so they deferred angioplasty, referred to higher center. So we did the femoral function, and in every step of this PCA, we avoid giving contrast, and with IVUS imaging, we just assess the block, adequately optimize it, and put a stent according to the IVUS imaging. So we are passed the wire into the LCX. It has crossed the 100% block here. Then is the IVUS catheter. We are assessing the landing zones where we have to land the stent. So this is a IVUS operating system. And when we took, after dilatation, when we took the IVUS image, there are a lot of thrombus in the LCX. So we have selected the stent size. Till now we have not given a single drop of contrast. So we have put a stent here, and again here we have selected the post-dilatation volume according to the IVUS sizing and dilating it. And this is again pullback of the IVUS after stenting. You can see these are whitish spectral things are the stent struts. So it is adequately opposed with no malopposition. And later he had LAD lesion also. We did again LAD PTCA without any contrast. It's a double vessel disease. We optimized both of it. So we got a good result. And this is the only final check shot we have taken, consuming only 10 ml of Lipid dye. Creatinine trend was 2.2 on day 3, and day 7 creatinine was 2, and patient walked away without any requirement of dialysis or any decreased urine output. Take home message would be advances in tools of coronary physiology, imaging, calcium handling hardware helps to perform PCA with adequate optimization. Interventionists should use the above tools appropriately to get the best short-term and long-term results. Thank you so much.
It was a nice talk from Dr. Damodar. I think basically the gist of the story is there is a difference between simple angioplasty and a good angioplasty with a good long-term outcome. So all the new generation tools like IVUS, ultrasound, OCTs are used to improve the patency of the stents in the long term. So I think Dr. Damodar has nicely illustrated all the important tools. Being a cardiology-centric hospital, so we have got all these new generation tools readily available in our shelf. So where appropriate, we generally use these tools and improve the PCA outcome.
Thank you, Doctor. I now request Dr. Sharat to address the audience on the topic, role of complex and high-risk interventions in contemporary cardio.
Yeah, honestly, these are kind of exotic, presentations, but I like the first session because that's a session, to prevent patient ending up in this kind of stuff which we do. Yeah, so as we are progressing in innovations in interventional cardiology, more and more patients where previously the solution was only bypass are coming into the percutaneous solutions which we offer, and also sometimes patients where CABG cannot be done for various reasons, so those are also surgical turndowns. So there also we can find a solution. To simplify, what is a simple angioplasty? Let's say there is a lesion like this. There is a lesion like this, around 90%, 95% or 99%, but you know the way how to go. And if this patient has normal LV function, no other disease, no kidney disease, no lung disease, nothing else, no peripheral artery disease, I think that's a simple angioplasty. So anyone could cross, this lesion. I mean, if you stand beside me for 10 cases, probably 11th case you can do. You can cross with a wire and, you can put a stunt and you can come out. So, but what is complex and high risk angioplasty? So, let's say the block is sitting here. This is a left main coronary artery. You can understand that downstream, this entire myocardium is affected by this LMCA. If it is in LED, only this part of myocardium. So, any position where the significant chunk of heart muscle is involved, those are going to be very high risk angioplasty. So, this LMCA involvement is, high risk angioplasty. And sometimes, like this is a right coronary artery, and you can see there is a segment missing here in the middle. That is nothing but a total occlusion. So this is a segment, which is missing here. You can see that's 100% occlusion. So the distal part is filling from left system. So this is 100% occlusion. So these are called as chronic total occlusions, and these are the cases where high expertise is required, to achieve a good revascularization. Sorry, I think slides are overlapping here. So sometimes, patients do have multi-vessel disease. You have all three vessels diseased: LED, LCX, RCA, LMCA. Disease is everywhere. That is a multi-vessel disease. Again, those are very complex and high risk. And often these are the patients, they end up in surgeon saying bypass, cardiologist saying stenting, and probably they also end up in your clinic asking, sir, what should I undergo? See, one is saying bypass, one is saying stenting. So, we have a good culture in our organization wherein, we all sit, including our surgeons who are sitting here, we all sit together and discuss about the patient, and we keep patient in the center, and then we decide what is appropriate for the patient. So this is heart discussion, which happens on every case where there is a controversy. So in multivessel disease, we have certain scores known as syntax score. It is an anatomical score decided based on angiogram. Based on that, we decide. So if the score is less than 22, that's a straightforward case for stenting. And beyond 32, it is bypass. And less than 22 to 32, anything can be done based on the other feasibility. And when we think anatomically patient needs bypass, the next question is whether the patient is suitable for bypass or not, right? So if patient is suitable, that is surgical risk scores. If patient surgical risk score is high, again, we come back and think about percutaneous solution. If surgical risk scores are low, those are the patients who go for bypass. You can see this patient, 84-year-old, COPD, renal failure, CVA, and recurrent ACS with heart failure, and he has diffuse disease in LAD and also left main coronary artery and also RAMS and also diffuse disease in right coronary artery. So this is a typical high octane case for anybody. And obviously surgeon would reject, and this patient also had a left carotid total occlusion. It's not just heart blood vessel occlusion, he had a brain vessel occlusion, he also had occlusions in all peripheral vessels. And 84 years. So any surgeon will say, I don't do anything on this patient. So, but when patient is recurrently admitting into the hospital, obviously we have to find a solution. Is a clearly high surgical risk, and obviously we end up in doing a PCI, right? So we did a PCI. You can see we treated LMCA, LAD, and also RAMS, and this patient did well for 4 years, but COVID took away him. So that's the sad part of the story. So, and you can see this is another patient, again 66-year-old CKD on hemodialysis, had a GI bleed, for which he was taking regular transfusions at least thrice a month, and came with a chronic stable angina. This was a problem, very discrete lesion in LAD, and very discrete lesion in LAD, and discrete lesion in LAD, and very discrete lesion in RCA. So otherwise it is a straight case for angioplasty. There is no need to think about it. But the only problem was, in this patient, if I do angioplasty and give 2 dual antiplatelets, 2 blood thinners, these guys will end up in, as Dr. Balaji showed, he might come back with a major GI bleed. So you are treating heart, but you are giving a major GI bleed because this patient already had an obscure GI bleed. So that was an issue. So if you do an angioplasty, you have to do the single antiplatelet, or otherwise, you have to do bypass. So this patient was recommended bypass. He came with that recommendation to us. But when we looked at his surgical scores, he's a very high surgical risk. So obviously what happens is here, I have 2 choices. You do bypass and accept a 30% mortality in this patient, or do an angioplasty with a single antiplatelet, not like 2 antiplatelets, and still accept a mortality of around 4-5%. So these are the 2 options which we can honestly discuss with the patient. There is nothing like a guideline here. You have to just use your data and talk to the patient. Finally, this patient, we ended up in doing angioplasty. So we kept 2 stents, one in LAD and one in RCA with latest regulating stents, and we had a good result. And we initially tried giving a second antiplatelet, but patient had increased transfusion frequency. That's why we immediately removed second antiplatelet within 20 days. And he did well. Again, I'm sorry to say that this patient also gone in the second wave of COVID. So, and this is the next case. I think it's a patient came for femur surgery. He had, I think, fractured femur at the knee joint, twice operated, but again ended up in problem and came for a third surgery to us. During pre-op evaluation, we found stress test was positive, and we did an angio. You can see LAD is tightly diseased here. So you can see LAD is tightly diseased. So LAD is tightly diseased, tight disease. So what to do to this patient? Again, it's a simple single vessel disease, a simple lesion, which anybody will do, angioplasty. But the problem for which patient came to hospital is not his heart problem, for his knee problem, which is affecting his quality of life. So what we have to do, offer for this patient? So if you do angioplasty and you end up in continuing dual antiplatelets, what will happen to his knee surgery subsequently? So there is obviously high risk of bleeding and obviously high risk of infection, and we have to understand the fact that this is the third surgery, knee surgery for him. It's not the first knee surgery. So we don't want a fourth surgery for this patient at the knee. So we gave an option. So in such patients where you are discontinuing antiplatelet therapy shortly because of non-cardiac surgery, it is reasonable to offer patient with a minimal invasive CABG, and later we can do his knee therapy 1 to 2 weeks later when our patient recovers fast. Another option is do a PCI, put 2 antiplatelets, but always explain the patient possibility of failure of his knee again, or complications during his knee surgery again. And we did basically, and we have wonderful surgeons, Dr. Krishna and the orthopedician. I think they operated together on this patient. Both the surgeries done simultaneously, and patient got discharged in 2 weeks' time and is doing fine. So sometimes you can see this patient, we did an angio, and there is a tight LMCA disease. We were discussing, in the console room, what to do to this patient. Bypass, stunting, advantages of bypass because it's an LMCA disease. We always discuss 2 options. While I was discussing with the patient attendance, patient collapsed in cath lab table. So that's what can happen in a left main coronary artery osteal disease. So honestly, we wanted to give all the options to the patient, but patient never gave us time. He collapsed on table. That's when I have only one option. When patient is stable, I can think of all the plotter of options. But when patient is unstable, sitting, lying on the cath lab table, it's straight option. That is only one thing, because emergency bypass is almost we are not doing these days because of chances of complications. So we took this patient immediately for stenting, and we kept an IABP and we stunted, and he's doing fine in follow-up. So this is another case. You can see there is a simple LAD 99% lesion, and you can see this is a chronic total occlusion of right coronary artery. He was recommended bypass. He came to us. See, in this case, it is the capability of operator and the success rate of center in doing CTO interventions that is paramount in taking decisions. If patient is in a center where the CTO cannot be done with a high success rate and low complication rate, straightly these patients are sent for bypass. But if there is an operator with a high success rate and low complication rate, these are the straight cases for PCI. So the decision of PCI versus bypass also depends on the capability of interventionist as well as availability of the hardware, which Dr. Sridhar was speaking about. When you have everything in your cath lab to handle these kind of patients, we can do it. So this is kind of, we did LAD followed by right coronary artery. This is known as retrograde approach. We go through these small bypass channels and open these vessels and close it. I think what's the time? And we completed procedure. So the capability of center is also very important. So what essentially I showed, there are lesions which are stuntable and straightforward, but I advised bypass because of the clinical situation. And there are lesions where I showed you bypass is ideal, but I ended up in stunting because patient is not fit for bypass. So the decision of PCI versus bypass is not just by one CD, because often patient attendants walk into your room with a CD. So we can't decide based on a CD information what should be done to the patient. It has to be a holistic approach. And what is high risk PCI? I told you the anatomical issue. Sometimes when you are doing a PCI with already struggling LV function is reduced, that's when we have to be very careful. That is also another center of high risk PCI. You can see here, this is a total occlusion of right coronary artery with the patient, I need to know the time. So with the patient with LV dysfunction. So we were doing a live in-box case. Dr. Sridhar was with me in this case. We were doing CTO in a retrograde fashion through the bypass, and its procedure was almost about to close. You can see what happened. You can keep watching. His pressure is dropping, and you can see, heart is becoming slower and slower. At some point, one of our technicians jumps on the patient and starts CPR. So this is what happens. So high risk anatomy, and already patient had pumping dysfunction. Those are the patients who will end up in an on-table cardiac arrest. Though there was an issue, we completed this case with a good result, and patient is doing fine. In such patients, what is important is we have to maintain patient blood pressure during the procedure. So for that, we have circulatory support devices now. This is known as Impella, which I think we are the only center probably having Impella and control everything in our cath lab, which can be installed on the patient or commissioned on the patient at any time. So this is a pump which sucks blood from LV and leaves in the aorta. It is something like a pump. So even if patient goes into kind of arrest situation or near arrest situation, this pump will keep the pressure on so that the operator can complete the procedure. And this is another thing, VA ECMO, which can be used to make in advance and to complete the procedure. So these are the methodologies which we use. And this is one patient. I think the patient came from UAE. So he came for renal transplant, not for heart surgery. But the problem was he has severe pumping dysfunction, LMCA disease. He had LMCA disease, and he went around many centers. So urologist says, you get treated for your heart, then I will do transplant. Cardiologist says, and cardiac surgeon says, boss, you have a renal failure, your procedure risk is very high, that is 30 to 40%. So patient is
So going around cardiologist and nephrologist, urologist without any solution. And these are the patients where we can find a solution by doing all these techniques. So what we did, we installed Impella for this patient, and then we completed his revascularization, that is all stunting everything. And you can see at this point, patient pressure is flat. You can see here, this is how the patient pressure should be, and you can see this is almost flat. So that movement is enough for patient to go into a vicious cycle of events and die on table, and that is averted because of the presence of Impella there. So that's what we do. So we completed procedure. You can see here we completed procedure and we shifted patient out, and later we weaned off Impella. 3 months later we did renal transplant to this patient. This is 4 years down the line. Patient is completely free of even follow-ups, frequent follow-ups, no dialysis, and is doing fine. So with a good quality of life. So these are the patients where neither suitable for surgery, nor you are able to provide the solution to the patient. We can find a solution with these kind of devices. You can see this is a patient where there is a severe MR, and patient had LV dysfunction, and he has a disease in LMCA, and this is in RCA. Again, is a very poor subset, high tendency to have on-table cardiac arrest. And again, we did with, this is an Impella we positioned, and then you can see, while I was doing, there is a flat line. There was no LV contractility at all. So, and if this device was not there, probably I would have lost this patient on table. There were many such episodes during the intervention, so which we could avoid, by having this instrument there. So we completed. You can see this is all we completed, and later his MR came down and LV function improved, and patient is on follow up, doing fine. This is another patient, acute MI, came to emergency, went into cardiac arrest, right? And these are the patients where even if you do primary angioplasty, this patient may not come out. So the first thing what we have to do is, you need to have an MCS team in the hospital. You have to install VA ECMO for this patient. See, you can see while doing CPR with automated CPR machine, we went ahead, these are the ECMO sheets which are going in. We went ahead, we placed ECMO. First you place ECMO and reverse the circulation and protect all other organs, then you do angioplasty, then only these patients will survive. So that's what we did, and you can see this is the LED which is activated and opened, and these are the ECMO things which we continued for next 3 days, and later patients LV also improved, and we removed ECMO and then extubated and discharged patients. So, ladies and gentlemen, decision of type of revascularization, PCI or CABG, is a stepwise process. It's not, angiogram is not the end of it, it is only the beginning of it. So coronary anatomy may demand CABG, but unfavorable body physiology make PCI as the only feasible option. So like all these cases which I showed. And sometimes coronary anatomy is suitable for PCI, but probability of antiplatelet interruption may favor bypass surgery, which we have to be keep in mind. And capability of center and operator to perform complex and situ procedures and protected PCI procedures plays a role in decision making in good number of patients. And the availability of tools like Impella, VA ECMO, rotablation, laser, all the stuff which Dr. Damodar has showed before is paramount in treating very complex and high-risk patients. And where all this stuff starts is with the heart team. So a team, cardiac surgeon, cardiologist, anesthetist, sitting together and discussing and coming up with an option is the most important thing for all these patients, rather than everybody giving a different decisions. Thank you.
Thank you, Sharat.
I think that is the most balanced and nice presentation I've seen. Because as you rightly said, your take-home slide says it all. It is not what I know I want to do, it is about what is the right thing for the patient that should be done to get the best outcome. And with more advanced technology, people can get easily carried away, saying that, okay, I can do this, I have the capability, let me try this on this patient, but that's not right. Having a balanced approach and doing whatever is right for the patient is absolutely right. And I think you nailed it when you said capability of the center is a most important criteria to take up complex cases. When you mean capability, having all the necessary equipment, paraphernalia, people, and all those things are available. So yes, I think it's a wonderful presentation. Thank you.
It's a nice presentation. One question for you is, I think all these complex angioplasties comes with certain amount of cost. So how in your practice will justify the patients and relatives and the referring doctors with regard to the cost of these procedures?
I mean, what we all should understand is, I think number of BMWs and Benzes in this country are more than what the country which is manufacturing is having. If I'm correct, Dr. KP can add because he stayed in UK for long, right? So, yes, no doubt cost is a concern, and no doubt these kind of therapies can be given and offered to the patient only when physician is at his free will to think. If physician is, I mean, if I'm, handcuffed and ask by the patient, you do the case, obviously it is better you walk out of the case, don't do that case. Because you have other alternative options which are cost effective, like surgery. Surgery is definitely a cost effective option, but in patients where surgery is high risk, it is reasonable to offer this therapy to the patient. And if you can take it up, it's fine. If you can't take it up, I think you offer whatever you can afford.
Yeah, again, a very important point, and particularly in the context of our country and the way we practice. This practice of giving packages has crept into corporate and private hospitals, which is good, but it has its own bad things. It's a straightforward case, a package is good, but these are extreme cases. In extreme cases, if you want to use extreme technology, the latest technology, then cost should not be this thing. It should not be a barrier, because that barrier is there in the mind. You cannot operate freely and do what is right for the patient. So yes, patient and doctor have to communicate and clearly explain each other that, okay, this could be costlier, and only once they agree, you should go about it. This concept of packages should slowly go away, because we are no longer a third world country. You rightly said, the number of costly cars that go around here and the number of jewelry shops that are there in our city, every locality, are much higher. So people can afford it.
Partly Sridhar is also true. Patients coming in BMWs, RDs with Arogya card are also there in this country.
Yeah. Thanks, sir. Thanks. We'll move to the next speaker.
Thank you, Dr. Shivan. I'm delighted to introduce Dr. Loknath, consultant interventional cardiologist, who will be enlightening us on non-surgical heart valve implantation.
In all this, please don't think that we forgot about the audience. If anyone has a question, please raise your hand and do ask any of the panelists at any point of time. Even if you have missed the talk, you can go back and get the panelists and discuss. The whole idea is to not only share information, but get feedback as well. So it would be wonderful if people have any questions, please do ask.
Yeah, good evening everybody. Today I am going to discuss about the non-surgical heart valve implantation options that we are having. So way back, mechanical prosthetic valves are a tail amount of cages, balls and discs. Initially we used to have a caged balls. The first valve prosthesis was a sutureless valve, which was designed by the Charles Hufnagel in 1952. and it was like this. It was the first prosthetic heart valve in 1952. The device is an acrylic ball and is inserted into the descending aorta. So this prevented only the descending aortic regurgitation from the descending aorta. So coming to the aortic valve replacement, from the older days of conventional open chest sternotomy to the present day minimal invasive like right anterior thoracotomy mini sternotomy approach. This is how it is done, where the in the open technique, the front wall of the chest is open. So after, so they will do this is the sternum. So they will create an incision. First they will do an incision over the sternum. They will open the sternum through the midline, median sternotomy. There are other approaches also where they will do. So after opening the sternum, they will with retractors they will open. There is a pericardium over the heart. So when the pericardium is open and the heart is exposed, so these are other sutures. So they will connect this, once the pericardium is open, they will connect the heart to the heart-lung machine, which acts as a body's lungs and heart during the procedure. So they will use a cardioplegia, that way the heart is stopped with the potassium-rich solutions. Once the heart is arrested, the aorta is clamped. They will clamp the aorta and they will open the aortic valve and they will replace the aortic valve with the prosthetic aortic valve and they will suture it. So this stage, whatever said and done, it's a surgical procedure. It takes a long time. It takes a longer time, a long hospital stay, and it takes a lot more time for the patient to improve. So what are the other options that are left for the patients? So aortic valve replacement can be performed through even through a keyhole and the minimal invasive surgeries. With minimal invasive surgeries, the recovery will be quicker and they will be having a better breathing and a faster discharge from the hospitals. And there will be lesser amount of cosmetic problem. So, and there will be a lesser chance of infections, there are lesser bleeding and trauma and the shorter hospital stay and a faster recovery. So now we are in the era where we are doing all the valve replacements through the small transcatheter procedures. What we are going to do is, we are going to puncture the femoral artery and after puncturing the femoral artery, we are going to put a wire across the aortic valve. This is a wire across the aortic valve and we are going to do a balloon to the aortic valve. After ballooning, we are going to implant this latestly available TAVI valves. We are implanting the valve, we are deploying the valve there after seeing the position. Yeah, valve is deployed. So, in this procedure, we need not open the chest and there is less chance of infection and there is a faster recovery. So, what are the conditions which favor the surgical aortic valve replacement than a transcatheter replacement? If at all the patient is younger, if at all the patient is having a bicuspid aortic valve, and if at all there is a problem with the femoral axis, and if at all there are low coronary astia, along with aortic stenosis or regurgitation, if at all patient is having a multivessel coronary artery disease, then it's better to get a patient surgical AVR done. If at all the patient is friable, if at all the patient is older age, if at all it's a redo surgery, if at all surgical access is available, if at all it's a already radiated chest, or if the patient with the porcelain aorta, it's better to go for a TAVR. So there are many cases, but this is the latest case that we have done. A 67-year-old male presented to hospital with severe calcific aortic stenosis, severe mitral regurgitation, severe tricuspid regurgitation, and moderate pulmonary hypertension, with severe biventricular failure and cardiogenic shock, and he is already having acute liver failure and acute kidney failure. So he was started on inotropes and diuretics, and we have done a coronary angiogram, which was normal. So we have done we have decided that we will do a TAVI as the surgical risk score is high, and it is very it is nearly impossible to operate on this patient, and we have done an angiogram as per the TAVI protocol, and this is, you can see that this is the echo pre-TAVR. You can see the severe calcific aortic valve hardly moving, and there is a moderate MR. And moderate PAH also. You can see. So we didn't have any other option except to do a TAVI for this patient. So we have done a CT aortogram, and so the surgical risk scores are very high. So definitely surgery is prohibitive. So we have done. We went ahead with the TAVR. So this is the axis that we take. Normally we don't do a surgical cut down. We routinely do a percutaneous approach only for the vascular axis, because we have a lot of perclose devices, ProGlide. So after taking the axis, we have taken a introducer's sheath over the extra stiff wire, and we have kept a TPI, and after passing the aortic, we cross the aortic valve with the JR with the straight tip Tegmo. So we have done a pre-dilatation over Safari. This is a valve that we are discussing about. So we take a pigtail injection, and we have deployed the valve. So this is the final ventriculogram. You can see there is no aortic regurgitation or paravalvular leak with good flows in the coronaries. So after doing the procedure, his mitral regurgitation improved, his pulmonary hypertension came down, and he is off inotropes, his acute liver injury improved, his acute kidney injury improved, and he is symptomatically better, and he was discharged. If at all we would have subjected to surgery, or if you have left him, he would have died. So next is a mitral clip that I am discussing. Actually, mitral clip is taken as inspiration from the Elifari stitch that is used for the mitral regurgitation for the Barber disease. So what they will do is they will stitch the anterior and posterior A2, P2, and they will make a single valve into two slits. So taking inspiration from this, actually what they have done is so in mitral regurgitation, the blood will be flowing back into the left atrium. So because of this, the patient will be having a fatigue, breathlessness or swelling and chest pain. So what we will do in doing is, we will be taking the femoral vein approach, and from the femoral vein we will be passing the device, and we will first puncture the intra-atrial septum. After puncturing the intra-atrial septum, this is intra-atrial septum, we will puncture through it, and after puncturing, this is the mitral clip. So we will send the mitral clip into the mitral valve and we will hold the mitral leaflets. So we hold like this and we deploy it. So what will happen? This single valve orifice, it will become a dual orifice and the mitral, see how it is from the top view. This single valve orifice will become a two orifice because of the mitral clip. So similar to this is a for tricuspid valve, where again tricuspid valve also there is a clip like this. It is a tri-clip. We will go into the femoral vein IVC and from there we will catch hold the. This is the mitral. This is tri-clip. So this is a anterior. This is posterior leaflet. This is a septal leaflet. So we will catch hold the septal and anterior leaflets with this leaf, with this clip, and we will decrease the tricuspid regurgitation. We will decrease the areas. Once we catch hold of this, you can see how the valve behaves. So the regurgitation will come down after the tricuspid leaflet, after the positioning of the triclip. So our conclusion is transcatheter valve procedures can be a valuable option for patients with valve diseases, particularly who are at high risk of surgery. So optimal patient selection is a crucial step in these procedures, and transcatheter valve procedures are less invasive, requiring less hospital stay, less complications, and no anticoagulation. Thank you. We are a level 1 TAVI and PMVR center, and we are a level 1 chip center also. So whenever cases are there, you can refer to us. Thank you.
Thank you. Thank you, Dr. Lopna. So for long, the valvular diseases have been a territory of CT surgery. But there are some cases where patient has a very sick valvular disease, but the overall patient condition is sick enough for a surgery. The surgery is prohibitive. Now there are a lot of non-valvular options for valvular diseases, and we are all doing right here in Hyderabad.
Yeah, as Sridhar said, valvular heart disease was kind of the domain of cardiac surgeons. But now slowly what is happening is with improving technology, more and more patients are being done with percutaneous techniques. And at the moment again, the indications are changing every now and then. Earlier when TAVI was first introduced, the valve was made out of bovine jugular vein. So the size was an issue because the jugular vein was only of a certain size. But then once the crimp technology has come, now the same regular valve that we surgically put is crimped into the stent post and then they can deliver it. There are a few challenges as Loknath has presented, and I'm sure those challenges also will be overcome. I think this will be the future where without surgery most valve replacements or percutaneous techniques for valvular regurgitation lesions will happen. But as of now, we are at kind of a midpoint, so we will have to hold the space. And as cardiac surgeons, I think we should also embrace this new technology. More and more cardiac surgeons are getting to learn wire technology, so we are also getting into cath labs and doing these procedures. And TAVI, actually, when the procedure was introduced, TAVI stood for transapical valve implantation. But over a period of time, it became transcatheter aortic valve implantation. So that's just for information. Thanks. Next.
Before we delve into our next captivating cardiology topic, I would like to thank our esteemed doctors for their skillful guidance and valuable insights shared. Your expertise has enriched our seminar, and we are eager to continue learning from the discussion. Now, let's seamlessly transition to our next topic, electrophysiology, heart failure, and CT surgery. So let's keep the momentum going as we welcome our next moderators to the stage, Dr. Raidurgam, Senior Consultant Cardiothoracic Vascular Surgeon, Medicover Hospital, Dr. Sharath Reddy and Dr. Shiva Prasad Naidu. I now invite Dr. Kumar Narayan, Senior Consultant Cardiologist and Electrophysiologist to Medicover Hospital, to join us on stage and shed light on atrial fibrillation, diagnosis and management.
Thank you. Good evening, everyone. And shifting gears, I am a cardiac electrophysiologist. For those of you who haven't heard that term, so cardiology is also developing so many subspecialties now. And electrophysiology is the specialty which deals with heart rhythm disorders. So today I am going to try to summarize the main points what you should know about atrial fibrillation diagnosis and management. So this is not an uncommon scenario in which you all might encounter. A 56-year-old successful businessman with a very hectic schedule has hypertension but often forgets to take his pills. So after a cocktail party with some important associates, he becomes short of breath, has palpitations and come to the emergency room. So for many of you, this may be an iconic ECG. You find a obese gentleman in some distress with high blood pressures, and this ECG is something which all of you should be very familiar with. So what are the hallmarks of the so-called atrial fibrillation? It's a completely disorganized and chaotic atrial rhythm. So first point number one, your regular P waves which represent atrial depolarization are gone. They are replaced by this fine fibrillatory waves, and sometimes these may be so fine that it may just look like a flat line. You may not find any atrial activity at all. The second hallmark is irregular RR intervals. So we know most of this from our MBBS days. A clinical AF is generally defined as an episode which lasts at least 30 seconds. So again, to recapitulate the key features, lack of P waves and then replaced by F waves or fibrillatory waves and irregular RR intervals. What is the basis of this AF ECG? This is important to know so that you can recognize its variance. So you have completely chaotic activity in the atrium, but then that rapid rate thankfully doesn't get all conducted down to the ventricles. Otherwise, every episode of AF will be fatal if the ventricles also start contracting at such a rapid rate. So you have the gatekeeper here, which is the AV node. And the AV node doesn't conduct all of those impulses down. So only some of them come through, and therefore, depending on the variable rate at which the AV node conducts these impulses, you have a irregular RR. So some of the variants also you should learn to recognize. Here is a similar looking rhythm, but the QRS is broad. So what's happening here? This is aberrancy. So when you see an irregular ECG and the QRS looks like a typical bundle branch block, think of AF with left bundle aberrancy. I often see this misdiagnosed as VT. And when there is a lot of irregularity in the RR intervals, look at it carefully again. This could possibly be AF with a bundle branch aberrancy. This is an ECG which you will not see commonly, but represents one of the true emergencies in rhythm diagnosis. If you see again an irregular RR but with an extremely rapid rate and also a completely bizarre looking QRS. This doesn't look like any bundle branch block. Think of AF with WPW syndrome or pre-excited atrial fibrillation, which can be sometimes rapidly fatal. It can degenerate into ventricular fibrillation. Can you have AF with regular RR intervals? We have always been taught irregular RR. But as I already said, the basis for that is the variable conduction through the AV node. So what if the AV node stops conducting? So then you end up with a situation where you have AF but the RR is completely regular because there is no conduction through the AV node. This is AF with complete heart block. So this is sometimes misdiagnosed as a junctional rhythm. Again, you should know the background of the patient, whether he is known to have AF. And again, if you can recognize some fine fibrillatory waves, that may help you to understand that this is actually AF with complete heart block, the one situation where you can have a regular RR interval. Why should we bother about AF? The problem with AF is that every one of you, whether you are a physician, an orthopedician or a gynecologist, AF is not going to leave you alone. It is the most common arrhythmia and it can occur in any situation. Any stress can precipitate it. Post-op situation is one common situation. So people are like, okay, I'm a surgeon, I just operate, but unfortunately post-operatively the patient is going to have AF. So this is something which most of you can't escape from, and it is really the most common arrhythmia you encounter. Is it benign? Unfortunately not. Over a period of time, AF is indeed a risk marker. It more than doubles mortality, and one of the important morbidities due to AF is stroke. How do you think about AF? The 3 P's, as I like to call it, are important. You have paroxysmal AF, which is intermittent. It pretty much usually spontaneously terminates less than 7 days, or it gets treated within 48 hours of onset. Little longer lasting, we call it persistent, which lasts more than 7 days or gets treated more than 48 hours after onset. Long-standing persistent is more than 12 months. And permanent AF refers to more a clinical decision where you have tried everything, you can't get the patient out of AF, and AF is accepted as a permanent rhythm. I will not go into the genesis of AF for the simple reason that most people haven't understood it completely. The classical theory which we have all learned is totally chaotic, there are multiple wavelets all colliding in the atrium, it's all complete nonsense going on in the atrium. Thankfully there is a little more progress now. We know few things. We know the pulmonary veins in the left atrium are an important trigger. Many times the trigger for AF comes from that, and this has important therapeutic implications in the form of AF ablation. Second thing we have learned is AF in many ways is a systemic disease, and it contributes to the abnormal atrial substrate. So we use the term atrial myopathy. So there is a lot of adverse remodeling in the atrium the longer AF goes on, and that results in perpetuation of AF and also leads to certain other adverse outcomes. So there are twin problems of AF. One, very important one, the cause of lot of morbidity is thrombosis. The most devastating manifestation is stroke. The second issue fundamentally with AF is it contributes to abnormal hemodynamics. So you lose the atrial contribution to cardiac output, you have fast heart rates, and this can lead to a bunch of problems including heart failure and worsening potentially of other conditions like coronary artery disease. So how should we manage it? We think traditionally in terms of 3 pillars of AF management. One is treating the arrhythmia itself, either by rhythm control or rate control, and the other important thing is stroke prevention. But before all this, there is another very important thing, and it really should be the 4th pillar and should come first, and that is risk factor management. Because as I already alluded to, AF is in many ways a systemic disease. It's also a risk marker. It shows you overall how good the cardiovascular fitness is in many cases. This is one simple example. This is a large study which simply looked at weight reduction. And if you ensure a good weight loss regimen, the AF burden significantly comes down. Another important risk factor which Dr. Balaji alluded to, obstructive sleep apnea, often underdiagnosed and not thought of in the outpatient management. I have seen several cases that the AF was resistant to every management until the obstructive sleep apnea was treated with CPAP, and then the patient came back to sinus rhythm. So sometimes you'll be banging your head against the wall, just focusing on the arrhythmia alone, but you need to look at the overall picture. So there is enough evidence now to show that aggressive risk factor management, adequate control of blood pressure, diabetes, weight loss, treatment of OSA, all of them can bring down your AF burden. And if you look at other exotic treatments like catheter ablation, they may not succeed unless your basics are right. So in treating AF, how will you go about it? Do you just control the rate and then leave the patient in AF? That is what is known as rate control. Or would you want to aim to get the patient back to sinus rhythm through whatever means? That is known as rhythm control. And is rhythm control really a cure for AF? So this is a very famous trial which was done a very long time back, which was called the AFFIRM trial. They just compared rhythm control and rate control and saw
does rhythm control work better? And we found surprisingly that it didn't do better. In fact, the outcomes were slightly worse in the rhythm control arm. So what's going on? Because common sense, you should think that the patient should do better in sinus rhythm. So it turns out that the way we try to usually maintain sinus rhythm is not great. We use antiarrhythmic drugs. All antiarrhythmic drugs have side effects. They have what is also potentially known as proarrhythmia. They may trigger other arrhythmias. So what we have learned over time is that the benefits of maintaining sinus rhythm could potentially be negated by the adverse effects of antiarrhythmic drugs. No doubt, sinus rhythm is preferable, but we still are figuring out the best way to achieve and maintain sinus rhythm. Having said that, does rhythm control have no role? Not at all. When do you choose rhythm control? You choose it especially if the patient is really troubled by AF. There's a lot of symptoms. Younger age, where the comorbidities and the atrial substrate is likely to be less, you are much more likely to be successful in maintaining sinus rhythm. Which type of AF? The paroxysmal AF or the intermittent AF, you have a greater chances of success with lesser adverse effects and with lesser comorbidity. So how do you go about rhythm control? You think of it in two ways. Acute rhythm control, when the patient is say coming to the emergency room with an acute bout of AF, or a chronic, how do you maintain the sinus rhythm in the long run? Now, one of the questions is when a patient comes to the ER or he comes to you, let's say the OPD saying, I have a lot of palpitations, dyspnea, you find the patient is an AF with fast ventricular rate, what to do? Should I immediately cardiovert the patient? And what should I do? There's a lot of uncertainty sometimes. So what are the situations where you think of immediate cardioversion? One is if you are clinically reasonably sure that the AF is of new onset, and by that we typically mean within 48 hours. Now, one situation where there will be no question, not only for AF but for any arrhythmia, is if it is causing hemodynamic compromise, if it is causing a drop in blood pressure, if it is causing severe heart failure or angina, don't think twice. You need to get the patient out of that rhythm immediately because it's life-threatening. So, in those kind of situations, immediate electrical cardioversion is the way to go. But if not, then one important consideration in AF is you have to think of this stroke risk. The problem with AF is AF has gone on for some time and then you try to abruptly convert the patient. There is a possibility of atrial stunning and an increased risk of stroke. So anticoagulation status is important to think about. If there is no emergency to convert, then you either have to anticoagulate the patient adequately before converting, or if you want to do it more quickly, you should rule out a left atrial clot by doing a transesophageal echo and then think of cardioversion. There are two ways of converting. One is pharmacologic, using IV antiarrhythmic drugs, and we have two important agents, amiodarone and ibitline. And the other is to do an electrical or a DC cardioversion. If you have to defer cardioversion because of stroke risk, meanwhile you can institute rate control for symptom relief. As far as chronic rhythm control is concerned, we have two main classes of drugs. We have the class 1 antiarrhythmic drugs, that is flecainide and propafenol, and class 3, that is amiodarone and sotalol. Most of you may be familiar with amiodarone, and the other antiarrhythmic agents tend to get underused. So when should you use these class 1 antiarrhythmic agents, flecainide or propafenol? To summarize it simply, in a patient who does not have significant structural heart disease in the form of either LV dysfunction or significant left ventricular hypertrophy, or significant multivessel coronary artery disease. In these situations, class 1 agents are better to choose because they have lesser long-term side effects as compared to amiodarone. Amiodarone, you may be aware, is a slew of long-term side effects including thyroid, retinal, liver function, and so on. So there is a space to use class 1 antiarrhythmic agents, and we should keep that in mind. What about catheter ablation? So catheter ablation is possible for atrial fibrillation. But the key point which I want to tell you is that it is not as highly successful as, for example, for supraventricular tachycardia. That is because AF is multifocal in origin, number one. And number two, as I already said, there are a lot of systemic factors which contribute to AF recurrence. So, but what do we do when we talk about AF ablation? What we do is we eliminate the triggers around pulmonary veins in the left atrium. That's the most common procedure which is done for AF ablation, and that is known as pulmonary vein isolation. Who is the best candidate for ablation? Not everybody. Suppose you have a 85-year-old gentleman who has got long-standing hypertension, whose BMI is 36 and whose left atrial size is 60, then that is not a candidate, and we are never going to take that patient for AF ablation because the chances of success would be less than 10%. What is the best candidate for ablation? Somebody who has paroxysmal AF, who is symptomatic, who is really being troubled by AF, is getting repeated palpitations, he or she is miserable, has no structural heart disease ideally. The chamber sizes and everything are normal, especially the left atrium, relatively young. So in such a patient, you have pretty high chances of success, and also the patient stands to benefit a lot because he is getting troubled so much by the AF episodes. What about rate control? It is default, it is the backbone of any AF management. Whether you do rhythm control or not, you should control the rate to relieve the symptoms. It is easier because you can use drugs with lesser adverse effects, and it's a reasonable standalone strategy, especially in very elderly patients, those who are not very symptomatic with AF, or where the situation, comorbidities look like sinus rhythm is unlikely to be maintained. An important point is, I see many times people aiming for extremely strict rate control. They say, oh, the heart rate should come to 60 or 70, then only I'm going to feel good. That is not evidence-based. This issue has been studied, and what has been shown is that a lenient rate control strategy, aiming for a heart rate anywhere for around 100 to 110 is pretty reasonable. Most patients have good symptom relief with it. And what happens when you try to aim for too strict a rate control, you start having high doses of drugs, you start experiencing bradycardia, other side effects, disease spells, and so on. So the lenient rate control is adequate for most patients, and you tailor it individually depending on how the patient is feeling with a certain heart rate and what dose of drugs you are having to use. And what are the drugs which you would use? The two main classes available are beta blockers and calcium channel blockers. And just like in the treatment of hypertension, you go by the other indications. Suppose the patient has coronary artery disease, you would prefer to use a beta blocker. Suppose the patient has poorly controlled asthma or COPD, you don't want to use a beta blocker, you would prefer to use a calcium channel blocker. Suppose the patient has significant LV dysfunction, then you want to preferably again use a beta blocker, which has mortality benefit in such situations. So you look at the surrounding conditions and then you decide which drug you would prefer to use, and you may use more than one drug if the situation permits to achieve your rate control strategies. The last point, but very important one, is stroke prevention. Again, sometimes this is forgotten, but you have to think of stroke in every patient whom you see with atrial fibrillation. Why does this happen? Because of atrial mechanical dysfunction. There is a clot which forms in the LA most often and then migrates to the brain. First important point, the prevention is not aspirin. I see again a lot of practice where aspirin is written and people think the job is done. If a patient needs stroke prophylaxis for AF, a lot of studies have shown that aspirin is not effective. And aspirin is not extremely safe. Aspirin does carry a sizable risk of bleeding. So again, there is another common misconception I come up with. Say, let me like aspirin because this patient is at risk for bleeding. Aspirin does carry a risk of bleeding by itself. So if you really want to give an effective therapy, it is anticoagulation and not aspirin. A lot of studies have already shown that it reduces stroke and mortality. What are the important considerations? Of course, you have to assess what thromboembolic risk this patient has. And the contralateral side to it, what is the bleeding risk? And then you have to select the appropriate agent. So there are a lot of scoring systems. I would all encourage you to be familiar with the CHADS-FAST scoring system for assessing thrombotic risk, which has a set of common clinical factors: congestive heart failure, hypertension, age, diabetes, prior stroke, vascular disease, and two other intermediate age and female sex. So based on this, you can have a potential scoring system, and generally the consensus is that if the CHADS-FAST is more than 1 for males and more than 2 for females, that is 2 or more in males, 3 or more in females, anticoagulation is required. The chance of 1 in a male and 2 in a female is a little borderline. There you have to individualize the bleeding versus the embolic risk and also see which is the risk factor which is contributing. If it's a solid risk factor like hypertension, for example, probably the patient will be better anticoagulated. Another important thing to remember in our context is these evaluations have been developed for non-valvular AF. We see a lot of valvular AF in our situation, especially rheumatic heart disease. These scores are not validated for that. To little oversimplified, most valvular AF would probably need anticoagulation, especially if it's rheumatic heart disease. There you do not apply these scores. The contralateral side, you have to consider bleeding risk. Again, there are many bleeding risk scores. This is one popular one which is called ASPLED. A score which is greater than 3 indicates a heightened bleeding risk. So what do? Does it mean you should not prescribe anticoagulation? Not really. Again, you make an individualized decision and then you just have to follow up this patient a little more carefully and warn them a little bit that they are at a higher risk of bleeding. So aspirin is not effective. There are 2 main categories to choose from. Vitamin K antagonists are a traditional warfarin or acetron, and the novel oral anticoagulants or NOACs. These are basically have a different way of action. They either inhibit factor 10, which is 2 drugs which are available, rivaroxaban and apixaban, or they directly inhibit thrombin, which is the agent dabigatran. So these are the 3 drugs which are available at present in India. And the advantage of NOACs is that compared to warfarin, an analysis of studies shows that they reduce the stroke risk a little better, and more important than that, they have a lower risk of bleeding as compared to warfarin or acetron. The other advantages are they have a faster onset of action. It's a fixed dosing. Unlike with warfarin and acetron, you don't need to keep doing PTINRs and adjusting them. The cons are they are more expensive and it requires dose adjustment, especially in endurance and renal dysfunction. And in extreme renal dysfunctions, most of the NOACs are contraindicated. 2 important situations where you should not use NOACs. One is a mechanical prosthetic valve. NOACs are contraindicated. And second is the situation of significant mitral stenosis. In these 2 situations, you still have to go with warfarin or acetron. So to close, I would say atrial fibrillation is an arrhythmia which you are invariably going to encounter. Sometimes you will encounter it incidentally in your OPD. Do not neglect that. You have to think in terms of modifying risk factors and also in terms of stroke prophylaxis, even in the asymptomatic AF which you did. All AF would generally need anticoagulation unless it's truly low risk. So apply the Chang-Sass score in all of them. Don't forget modifying the underlying risk factors which can reduce the AF burden, and pay attention to comorbidities and assess the whole picture. Rate control is the default in all patients, and rhythm control is applied depending on the situation, especially the symptoms. Catheter ablation can be curative in some of them, but you need to keep in mind that the long-term success rates are not as high as, for example, for SVT, and it does carry some risk of complications. When you see the young, relatively young patient with symptomatic and paroxysmal AF who is very symptomatic and not responding to antiarrhythmic drugs, that is when you should think of. Thank you.
Thank you, Dr. Kumar, I think, for a nice coverage of anti-atrial fibrillation. I think for audience to know, Dr. Kumar is one of the finest electrophysiologists in India, and he is internationally renowned, and he is one of the members in sudden cardiac death panel which did research in Asia and came out with a beautiful article published in NEJM. I think it's in Lancet, right? Lancet, I think Lancet. So, I mean, which was really enlightening, for all of us, that article. So, thank you, Kumar. I think any questions from the audience? I think it's too complex for me also to understand. So, but yeah, the final message is: if you identify an AF, don't think it is benign. So there are implications for AF. I think it has to be addressed, and all the ways and means were already discussed. So we'll move on to the next presentation.
field you're managing?
Yeah, good evening everybody. So the last topic, last but one topic of actually the heart failure management. So you have seen so many topics in the last two sessions. So all the patients whoever is suffering with CAD, atrial fibrillation, valvular heart disease, all these patients, if they are not treated timely or inappropriately, or sometimes even though they are treated appropriately like dilated cardiomyopathy, so then finally they will end up in heart failure, and then they may end up in advanced stages of heart failure. So advances in our interventional cardiology created a problem of plenty of patients falling into the heart failure. So this is the epidemiology of heart failure. You can see the incidence is same, but the prevalence is increasing. So because the most of the patients whoever is being treated with CVD, they are because of advancement in our therapeutics, they are living for a long time, and then they are staying with heart failure. And then if you see heart failure with reduced ejection fraction compared to the heart failure with preserved ejection fraction, heart failure with reduced ejection fraction is because of ischemic heart disease and dilated cardiomyopathy. So the incidence is almost same, or it's coming down because of our interventions. But heart failure with preserved ejection fraction, that is mainly because of multiple comorbidities, that is increasing. If you see the impact of heart failure on mortality, the 5-year mortality is around 50 to 75%, which is very significant. The most common etiology is ischemic heart disease, that contributes to around 65% of cases, and second most is idiopathic dilated cardiomyopathy, that is 15%. Then we have to stress upon one thing is that always before labeling as a dilated cardiomyopathy, which is only 15%, we have to rule out ischemic heart disease. Always before labeling as dilated cardiomyopathy, we have to rule out coronary artery disease by doing either CT angio or coronary angiogram, because it makes a lot of significance to the treatment of the heart failure. So coming to the staging of heart disease, there are different classifications. One thing is ACC-HA classification. So at risk, that is without any structural heart disease, and then stage B with a structural heart disease but asymptomatic. Stage C is they are symptomatic, and sometimes they may improve with treatment and they may be in remission, and some people will have persistent heart failure, and finally advanced or refractory heart failure. But which is most important for our management point of view is this classification depending upon the 2D-ECO EF. So it is classified as EF of less than 40%, that is heart failure with reduced EF. The most of the data is in this classification, this stage. The second thing is heart failure with the intermediate EF, 40 to 50%. So there is less data, but we have to treat as if with reduced EF only. And the third category is normal EF, that is EF more than 50%. So then these patients, the data is limited, and then still it's evolving. But not just initial classification, we have to follow these patients regularly, and sometimes one classification they may improve one step, or sometimes they may deteriorate in future. So this is a natural course of heart failure. Usually patient will have some acute event like ischemic heart disease, arrhythmia, or any acute event. Then following treatment, they will be phase of stabilization, that is compensated heart failure, which will be interrupted by multiple decompensations, and then finally they land up in advanced stage of heart failure. So this is more important regarding our clinical management of heart failure. So because the acute heart failure, which includes Then go for some mechanical centrifugal support. And in cold and wet, the same. So if BP is less than 90, so start inotropes and then vasopressors, and then if BP is not improved and early, you have to identify the patient who is requiring mechanical centrifugal support. In acute heart failure, our goal should be one thing, hemodynamic support, then decongestion, proper decongestion, and then identify etiology, especially ischemia and arrhythmia and other treatable causes. And in case of the chronic heart failure, decompensation may be because of anemia and other factors, infection. And then we have to initiate GDMT within the first same admission. So hemodynamic support, use as minimum inotropes as possible. And then if patient is not improving with inotropes, go for mechanical centrifugal support. Decongestion, most of the chronic heart failure patients will be resistant to diuretics. So then you have to keep it in mind. So there is a gut congestion that reduces bioavailability of oral diuretics, and there will be diuretic resistance. And that is the reason why we have to use IV, and then we have to use sequential blockade. Block at multiple levels, and then if it is not improved, go for ultrafiltration. Coming to the etiology, you have to rule out all the etiology, and then GDMT we will discuss in next slides. See, this is a diuretic resistance. If you use chronic loop diuretics, usually, so the amount of sodium absorbed in the distal to the loop diuretic will increase. So that causes resistance. That is the reason why you have to add a thiazide-like diuretic as well as mineral particle blocker which acts on the connective tubule. And then how to assess one on diuretics. So just starting diuresis is not enough. We have to see whether patient is responding or not. After starting a diuretic, after 6 hours, we have to see what is the urine output. If urine output is less than 100 ml, you have to escalate the diuretic. As well as you have to take daily weight. So usually, if a diuretic dose is adequate, the patient weight has to come down by 0.5 to 1.5 kg per day. If that is not there, we are not giving sufficient decongestion, and then patient will require long hospital stay as well as ventilation. So this is the thing, donkey analogy for the heart failure, this is well known. So the thing is, we have to remove the load on the already weakened heart by giving proper diuretics, vasodilators, ACE inhibitors, and then by giving beta blockers, but never try to exhaust the heart by giving inotropes. So usually we have to give it active inotrope score will be there. So that score, if it is excess, then that means that the mortality will be high. Patient has to go for mechanical circulatory support. And the second thing is, we have to initiate all the GDMT, that is foundational therapies, RAS inhibitors, beta blockers, SGLT inhibitors, all in hospital. So that study called Strong HF study, they added all the heart failure medicines before discharge to the optimal doses, and then it reduced 6 months rehospitalizations and mortality significantly. And coming to the hemodynamic support, so if the patient is on iron drops, you have to see, so the shock stage, recent sky shock stage stays there. So if there is only hypotension, but there is no hypoperfusion signs, no oliguria, and then no cold peripheries, and lactates are normal, so then that's okay. But once signs of hypoperfusion started, like lactates are increasing, and then oliguria, so this is the time, so you have to go for circulatory supports. So you can see the mortality, that is stage B only 7%, stage C 12.4%, but if you don't act there, the mortality increases to 40%. So early initiation of these support systems. So like basic support system is, one thing is intra-aortic balloon pump. So this is easily available and it's the cheapest one. So you can see, usually we will keep a balloon in the aorta. So above the renal arteries and below subclavian, it counterpulsates. So during systole, it will deflate, and during diastole, it will inflate. So because of the diastolic inflation, the coronary blood flow will increase, and then during systole, so it will reduce the afterload on the heart. But the thing is, it can support only up to 500 ml of cardiac output. It is not good for 2 sick patients. The second thing, as told by Dr. Sharat, so this is impella. So it has a motor pump here, so it just sucks blood from the left ventricle and pushes into the aorta. So, but this is one of the short-term support. This can be used for protected PCI, as well as if there is a reversible heart failure like myocarditis. So we cannot keep for more than for weeks. Only we can keep for a few days. The other thing is VA ECMO. So it can give support to the both pulmonary as well as cardiovascular system. Especially it is the best tool for circulatory support, and we can use in heart failure, as well as this is the one of the tools you can use for ECMO assisted CPR. The patient had a cardiac arrest, especially young patient with a shockable rhythm like VTVF. There is a witnessed cardiac arrest in front of us, and there is a proper CPR is done. Those patients, we can do CPR in our hospital. So we are doing eCPR with a almost 50% success rate. So then 50% survival for a eCPR patient, that is very good. And then during discharge, so immediate post-discharge period is the most vulnerable period. So before discharge, we have to assess congestion, decongestion properly. Usually clinical congestion will be late onset and then early to go, but there will be some amount of hemodynamic congestion will be there. If you discharge just because of your clinical judgment without this one, again patient will come back. That is the reason why we have to assess the clinical congestion, and then we have to do natriuretic peptide. Minimum 30% reduction in the natriuretic peptide compared to the baseline at the time of discharge, then that is the criteria to discharge. And then we have to assess X-ray and then ultrasound to assess the decongestion. There is even clinical score also given to assess this criteria. And coming to the chronic heart failure, so these are the foundational drugs. So these are 4 classes of drugs: RAS inhibitors, that is, and then beta blockers, mineral potassium blocker, and SGLT inhibitors. So these are foundational because each has independent mechanism of action. When given in a combination, it has an additive effect. You can see, so as we increase the number of classes, you can see the mortality has come down. So some brief thing about ARNI. So it inhibits RAS by acting on the AT1 receptor, and it stimulates natriuretic peptide system by inhibiting neprilysin. And it has 16% mortality benefit over ACE inhibitors. And then coming to SGLT inhibitor, so it has some diuretic effect, and then a natriuretic effect, and then it reduces the fibrosis, and then it causes reverse remodeling. That is the reason why it is used both in heart failure with reduced EF as well as heart failure with reserved EF. And the novel molecule is Vericiguat, which was mentioned by Dr. Balaji sir. So this acts on different mechanism. It increases soluble cyclic guanase activity, thereby by increasing CGMP, it reduces the fibrosis in the heart as well as the stiffness in the arterial blood vessel. So this is given for a person in heart failure. This is in pipeline. This is oral inotropic drug, omecamtiv mecarbil. So just adding more myosin ready to act with the actin filament. So that is the reason why it increases the inotropy, but yet to be included in the guidelines. So these are the studies of paradigm HF regarding ARNI, DAPA and regarding SGL inhibitor, and then Victoria regarding Vericiguat. These are into guidelines, but galactic HF still, that is regarding omecamtiv, not in trial. So not only drugs, there is a different concepts in a heart failure treatment. Previously we used to sequence according to evidence, like, so first we start with one class, after reaching 100% initiate one more drug, and then after reaching max target dose again initiate. So it usually takes around 6 months. But now the concept is rapid sequencing. So because if you take ramipril of 2.5 starting dose, and then maximum dose is ramipril of 10 mg. But once you start ramipril 2.5 mg, 50% of the benefit, maximum benefit, is seen with ramipril 2.5, that too within 40 days. That is studied in SOLVE study. That is the reason why it is better to start all the molecules at a starting dose. That is better than starting 1 or 2 molecules at full dose. That is the reason why we have to start all the molecules as early as possible, and then we have to try to up-titrate. So this is the strategy. Nowadays they are proposing that we have to start all the molecules simultaneously at the minimum possible dose. Anyway, for SGLT inhibitors it's a 10 fix. So then we have to up-titrate. And then regarding ARNI, do not, usually ARNI sometimes causes hypertension. Many times they, the moment you notice hypertension after starting ARNI, you will stop it. But usually it is because of some circulatory adjustment. So you can reinitiate, never stop it, and then they will tolerate. So in spite of this, there is a lot of misusage or underusage of GDMT. And then once this GDMT is done, still the patient is symptomatic, then we have to start add-on therapies. Suppose if the patient is on maximum beta blocker, but still heart rate is more than 70, add evaporating. It reduces hospitalizations. And if you have to check iron, so if your ferritin is less than 100, then again you have to give iron supplement. And then Vericiguat for repeat hospitalizations. And then digoxin only for symptomatic heart failure, just to reduce the hospitalizations, but not used routinely. So always give these 4 classes of drugs, but we have to down titrate, reduce the diuretics, and then reduce the dose of nitrates, so that you can increase other medicines. So if you are treating heart failure with reduced EF, patient still having symptoms, so up titrate the guideline directed therapies and down titrate diuretics and then nitrates. If the patient is already improved, so then do not stop the medicine. So probably the patient is in remission, but then almost 40% of the patients within 6 months again they will develop heart failure. This happens especially with alcoholic cardiomyopathies and those things. So we think that you treat it, but it's not a cure, again it will reappear. And then if the patient is having worsening HF, then the options are devices. So the patient is you can offer ICD and then CRT. If the patient is having some bundle branch block, so because the bundle branch block, the LV, that is free wall and septum, is not moving simultaneously, just you can do CRT, so that LV and the free wall and septum move simultaneously. That improves the cardiac output. And then regarding HPF, still now, so only drug approved is diuretics for decongestion, and second thing is SGLT inhibitors. As per ACCHA, it is 2A recommendation, and recent August 2023 ESC guidelines, it's a 1A indication.
but predominantly diuretics and then treating comorbidities. And in advanced heart failure, it is just like a malignancy, the mortality is very, very high. And then for these patients, the more treatment options available are either heart transplant and then mechanical circulatory support, but we have to identify early. If the patient is requiring frequent IV inotropes and then persistent symptoms, antiprogenin is persistently elevated, and then other organs are being affected, and then a hospitalization of more than one in a year, and in these cases you have that the patient is falling down, and then you have to offer other advanced therapies. The options are either transplant, mechanical circulatory support, and then just living on palliative therapy. The transplant is gold standard with almost 10 years survival of more than 75%. But the only thing is it requires a lot of motivation. In spite of our heart failure registry, we are trying explaining the patients with advanced heart failure regarding heart transplant, but it requires a lot of motivation. The second thing is donor availability and then problem with immunosuppression rejection. The left ventricular assist device, it's a lot of research is going into this area. It doesn't require immunosuppression, no availability issue, but the only thing as of now, it's a little expensive. This is heart failure, HeartMate or left ventricular assist device. So it has it runs on a motor, centrifugal pump. It has an inlet and then there is an outlet. Usually will implant by doing surgery. The inlet will be in the left ventricle and the outlet will be anastomosed to the aorta, and then the drug lamp comes out through the abdominal wall, and then it pumps out almost 4 to 8 liters of the blood from the LV into aorta, and then patient happily can mobilize. So now it has recent guidance has recommended as a class 1 indication for a patient with advanced heart failure who is dependent on inotropes, and in non-dependent patients it's a class 2 indication. So this is our case. 63-year-old and an old lady with the EF of MRI was only 8% and the frequent hospitalizations. This was seen by Dr. Balaji sir, and then so you can see this is the LVAD implantation done by our Dr. Krishna Prasad sir. So just we'll core the LV apex and then we'll put an implant to the LV, and then the outlet will be anastomosed to the aorta, and then afterwards you can see this is the implant, and then it causes negative remodeling, and then LV improved, and then patient finally discharged. Okay, so that heart failure is fast moving area of research. So just optimal GDMT can increase the survival by 8 years, and then by doing LVAD and then heart transplant we can increase the survival by almost 8 years. So giving almost 16 years of life to heart failure patients by treating properly with medicines and then timely advice of these advanced therapies, so which can add a lot of things to the heart failure patients. So, but only thing is we have to take it properly, and then we have to identify the patient properly, and then it requires multidisciplinary team. So we have advanced dedicated heart failure clinic in our center with a cardiology and the cardiothoracic surgery and electrophysiology as well as critical care team. Thank you.
Thank you, Dr. Nitin. I think fantastic presentation. I think it's HeartMate 3 is the first. It's first implantation in Hyderabad city, which was done by our team successfully. And this now I think 5 years survival is almost equivalent to the transplant. 5 years survival is equivalent to the transplant with this device.
Not inferior to the CABG is the gold standard. It's not inferior to the CABG. Almost 78% survival.
Transplant.
It's equal to the
LVAD versus transplant.
Momentum 3, 5 years data, so it is equal to the CABG.
Yes, that's what, Yeah, see, it's a transplant.
Sorry, sir.
So the 5 year survival of cardiac transplant is equivalent to, LVAD. Yeah, rather I can put it differently. LVAD survival is almost equalized to the transplant survival. And that's the reason now I think more and more destination therapies are happening. Like, heart transplant, it's not easy to get a heart, to transplant it to a patient. So you need to have a brain dead patient with a good heart functioning heart. So, and more patients are going on to LVAD. After HeartMate 3, I think the number of LVADs are increasing across the world. Yeah. Thank you, Dr. Nitin. I think we'll move on to a culmination of today's program, the last presentation. And we have our...
Thank you, sir. It's an honor to invite Dr. Krishna Prasad, Senior Consultant, Cardiothoracic Surgeon, on the stage to share his insights on minimally invasive cardiac surgeries.
Good evening, everyone. So, when everything else fails, what we do? We pray to God. And that's what cardiac surgery is. So, you always start...
We have to press citizen.
I'm coming to it. I always start my talk with a joke. Probably if you've attended my talks elsewhere, you would have known this. So there was one anesthetist who was very hardworking, but as you know, cardiac surgeons are very hard people to work. And all his life, he worked with this cardiac surgeon who was very difficult for him. So at the time of his death, angels came and they said, "You have been a very good man, you've worked hard all your life, so we want to take you to heaven." He said, "I'll come to heaven, but on one condition, that there should not be a cardiac surgeon in heaven. If there's a cardiac surgeon, I'm not going to come. I've had enough of this guy, all my life." So they said, "No, there is no cardiac surgeon in heaven, please come." So they take him to heaven. They walk through the gates of the heaven, and as they walk through, he sees that there is cardiac surgery happening, heart lung machine and everything. He says, "You guys, you lied to me. You said there is no cardiac surgery in heaven." They said, "Yes, there is no cardiac surgery in heaven. That is God practicing to be a cardiac surgeon." So that used to be the ego of cardiac surgery at one time. But what we have seen in the evening is the technology is advancing. And with advanced technology, we are getting more and more minimal in our access to treat patients. Again, coming to a presentation, I can assure you there will be no numbers, there will be no complex slides. I'm a surgeon, and you're all aware of the famous saying, physicians know everything, but they do nothing. Surgeons know nothing, but they do everything. Pathologists know everything, do everything, but it's too late. Patient is dead. Right. Let me start my talk. The moment we mention cardiac surgery, the two things that come to a patient's mind are death and scar. Well, because heart is the seat of life, even a common man says, where is your life? You point to your chest and heart. As long as heartbeat is there, people believe they are alive. And any surgery itself is painful, and when people are told that their sternum will be divided, it's not a pleasant thing to hear, and unless and until they are really forced, cornered by people, they don't accept that kind of treatment. But few facts, let us ponder on what's been happening. Mortality and morbidity have significantly reduced in cardiac surgery. Now we operate on patients who were deemed unfit for heart surgery 20 years back. I remember when, in my initial days, when I went to UK and we used to have heart team meets, the cardiac surgeon sitting at the back of the room, he says, "I do this case, I will not do this case. Treat him medically." They used to just reject patients left, right, and center. Now we go to cath lab and say, "Oh, you don't want to do this case? We will take it, we will do it." So we are working on more difficult patients now, but with improved results. And most mortality is due to patients' pre-op status rather than the procedure itself. Average mortality, I can say, is about 2 to 3%, which is quite improved when compared to many therapies that are there on the offer. But still, morbidity like wound infections, internal dehiscence, although they have decreased, they are a possibility. And modern technology can support sick hearts, as Nitin has presented. Now, I don't want to bore you with all these things, but what has happened is the advantage of minimal access surgery has been demonstrated in areas in general surgery, laparoscopic surgery, a smaller incision, a lesser inflammatory response, and a quicker recovery has led people to start thinking as to how we can bring this into cardiac surgery. And as we have seen in the evening, the competition is intense. If, as a faculty, we have to survive, We have to face the cardiologists who are coming with newer tools day in, day out, and they want to take away more procedures. That's fine, it's for the patient's benefit. But we also have to offer something good. And so the answer is minimal access surgery. So what is minimal access surgery? Is how we look at it. Earlier, surgeons used to look through the door, but now we have to look at it through a keyhole. So that's the difference. What we have to do, it is like repairing a watch. So you have to do the most finest job through a small hole. And there are additional factors. Because we have already committed ourselves into doing beating heart surgeries and complex procedures. We can't go back and say, look, I'm doing a keyhole surgery, I'll go back and do the biggest thing inside. No. We have to do all these things. So, as in the picture, it is like juggling balls and running at the same time. And maybe I could add, it's not running on a track, it is running on a treadmill. The speed of which can be anything. So, that's what the complexity is about. So, basically, the inside procedure remains the same, as the efficiency has proved beyond doubt, but the approach is different. And all cardiac surgical procedures are possible. So in the next few slides, I'll just go through how we approach each of these procedures for conditions. So, as I said, most cardiac surgical procedures can be done through minimal access. So CABG is possible, mitral valve replacement is possible, aortic valve replacement is possible, double valve replacement is possible. Of course, ASD and VSD closures are possible. Advantages, as we have recounted, small incision, quicker recovery, lesser painful, cosmetically better, and safe for a future redo procedure if the patient requires it at some point, and quick return to work. Here, one point I would like to add is one of the reasons of morbidity post-cardiac surgery is because there are two parts to cardiac surgery. One is the physical trauma that we cause through this major surgery, and second is the procedure itself. So in minimal access, what we are doing is by reducing the trauma, we are reducing the inflammatory response and all that happens post-operatively. And so only the effect of the procedure is there on the patient. Well, there are disadvantages obviously. It will increase the operating time. It is not good in an emergency situation. And if it is unstable or if something happens when you are doing minimal access, patient ends up having two incisions where you have to go through sternotomy, which is a fallback thing. And it is of course technically challenging. Surgeon has to relearn many of the things that they have been doing recently. I'll mention that when I show the instruments. New techniques have to be learned and adapted to. And at what cost? I put first thing as surgeon's life. Because the stress of doing the same surgery and dealing with another person's life and doing it in a technically challenged situations increases the stress for the surgeon itself. And so, well, we can argue either way, but yes, it's a stressful situation for the surgeon. But we require special equipment, special cannulae, so the procedure becomes more costlier. But the possibilities are immense. We can do any procedure in cardiac surgery, and how do we approach it? What are the usual incisions? Mostly these are mini thoracotomies. Either it could be right, left, or we can go axillary, periareolar, or anterior and lateral. And some procedures we can also do through mini sternotomies. And of course, nowadays more and more emphasis is happening into endoscopic and robotic procedures, which will really come close to what percutaneous procedures can be done. So usually the strategy is to go on heart-lung machine because, as I said, the procedure will not be any different. So we do femoral cannulation or SPC cannulation with special retractors like the one you are seeing here. This is called a soft tissue retractor, which retracts all the tissues, and with a small hole we will have a better view inside. And we have to use, of course, long instruments because we are working from a distance, and something called as a chicwood clamp rather than the usual clamps. So the instruments are different. They are usually having crocodile tips rather than the usual artery forceps that you see. They have a long shaft, and the actual mechanism works at a distance. And these smaller instruments, which like what we use as a castros, have a different grip. And so you are the way you lock and unlock is different from the usual thing. So if anyone of you have ever been to surgical theatre, you know how you open and close an artery forceps is totally different from what you have to do here. And the biggest challenge in minimal access is the limited maneuverability. Because outside the chest, my wrists and hands move fine. But when I go inside, the tip of the instrument has got only 2 directions of movement. There is no 360-degree movement inside the chest. So surgeon has to adapt. So some of the procedures, minimal access direct CABG or mid cabbage, in which we go through the left 5th intercostal space, and again all the full spectrum of CABG can be done. Total arterial using Lima can be done. You can do Lima radial. You can do on pump. You can do off pump. Beating heart with special octopus. 3 to 5 bypass grafts can be done. Of course, the time is double, but these are all possible. So usually this is the setup. We need a special retractor to harvest the left internal mammary artery, and then we have retractors, and then a special octopus, which is more bending and can be introduced through the skin, and it has a different head inside. So this is mid cabbage. Aortic valve, again the approach is through second intercostal space on the right side or through mini sternotomy. Inside, again, we can do all the cannulation from the incision itself, so there will be no second incision, and the valve replacement, it can be done. Any size valve can be implanted. Mitral valve, usually the approach is through right ling thoracotomy. Nowadays we are doing axillary, and there are surgeons who are doing it through second intercostal space. They can do double valve replacements as well. And one interesting approach is peri-areolar, so no incision. You just take an incision around the nipple, and through that endoscopically you can do mitral valve repair or replacement. This is interesting, but of course challenging. This is the axillary approach. This is all the patient will have scar-wise. A small scar in the axilla, no one would know that this patient ever had a heart surgery at all. And this is how it will look at the end of it. So some movements are different. I will not go into the details of it, but surgeons have to learn one step at a time and acquire these new skills. Last but not least, now we are getting into robotic era. So a word about robotic surgery. Although it is called robotic surgery, the robo actually does not do the surgery. We have robotic arms which are inserted into the patient. And so the nurse and the helper will be standing by the patient side, whereas the surgeon is sitting away from the patient and working on a console. So it is like he's playing a video game, and the actual robotic arms are doing the surgery. So not technically, it's not a robot doing surgery. It is the surgeon who's doing with the robotic assisted arms. This would be probably the future, because with this only 5mm ports, 4 5mm ports are enough to do any cardiac surgery inside. So that would be a perfect solution where small incisions, but any surgery is possible. Yeah. So again, small incisions and robotic surgery. So in conclusion, minimal access provides the best of both worlds. The advantage of PTCA is because it's a small incision. The advantage of CABG happens to be long-medial grafts. Now with minimal access, we can provide a small incision and the best of CABG. Same risk, less trauma, less inflammatory reaction, and early discharge and recovery. And there are enough papers that show that minimal invasive, by doing minimal invasive, we are not compromising on the quality, and the results remain the same. Thank you.
Thank you, Dr. Krishnan, for
God is always in heaven.
Krishnan might be 5,000. Anyways. like to note. So I think minimal invasive is something which is which really changed at least perception of cardiologists like me, because the age-old bypass surgery where the patient used to come back after 2 weeks, long incisions on both the legs, sometimes non-healing ulcers on the legs, and sometimes non-healing ulcers in the chest, and sometimes you see that hypertrophy of skin, all that stuff. So it was disheartening, to see such patients, after 6 weeks still struggling despite having bypass. So I think this minimal invasive is the way forward, and it really reduces the complication rates. And most of the patients, especially valve procedures, they come out of bed on day 3 and go out of hospital on day 4, day 5. I think that's amazing. And Robo, I think as of now it is still evolving. It's not completely into cardiac surgery. We have a Da Vinci Robo in our hospital, but most of the robotic surgeries are now abdominal because it has evolved in abdominal surgeries, but cardiac surgery it is still evolving. Yeah.
See, actually, Da Vinci Robo was invented for cardiac surgery, but because there was less takers, they expanded to others because the cost was extremely high. So cardiac surgeons across the world didn't take it up, so they had expanded. Now there is renewed interest. So there is a concept called total endoscopic cabbage, so T-cabbage. So with which you will only have small scars and you can do the entire surgery this thing. And as you rightly said, Sharath, see, gone are the days of arrogance of cardiac surgeons, as I mentioned at the beginning of my talk, where they consider themselves as God. I think the days have come where every one of us should start thinking, embrace technology, do what is right for the patient with as minimal invasion as possible, but giving the best results. Thank you.
Thank you. If any questions, otherwise we'll close the session. Okay.
Thank you, sir. I think it's time to end the session. Thank you all the esteemed doctors for your active participation and insightful contributions throughout this session. As we reflect on the insights gained and connections made throughout this enriching event, let us carry forward the profound reminder that every patient counts, every life counts, and every heartbeat counts. It is through our collective dedication to excellence in healthcare that we can continue to make a difference in the lives of those we serve. I extend our sincerest gratitude to our esteemed speakers and moderators for sharing their expertise and also to the dedicated organizers for their meticulous planning and execution, and to all the attendees for their active participation and contribution to today's success. Your commitment to advancing the field of cardiology and improving patient outcomes is truly commendable. Let us continue to strive for excellence in our respective roles, knowing that our collective efforts have the power to shape a brighter future for cardiovascular medicine and the patients we serve. Before we adjourn, Medicover Hospital invites you to join for dinner. It's an opportunity to unwind and network. Once again, thank you so much for the commitment, and now let's proceed for dinner. Have a happy day.
कार्ड फुल कार्ड
फोटो ना
लाइट से मैं जब लाइट से मैं लाइट से जो पहले लाइट से मांगे तो ये बात यार ले भैया 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 लाइट से मैं सब ब्लू చెప్పండి సరే ఓకే ఒక్క నిమిషం ఆగనా కొంచెం బ్యాక్ రా
ఒక్క నిమిషం రెడీ రెడీ సార్ రెడీ వన్ మోర్ సార్
వెయిట్
ఓకే 1 minute
ఓకే
కొంచెం వెనక
ఓకే ఒక్క నిమిషం జరుగుతా ఓయమ్మ మెల్లగా ఒక నిమిషం రెడీ సార్ స్మైల్
సార్ 1 second సార్ రెడీ
ఓకే పోయొచ్చు This is